Okay, so today's training is going to be on Washington State specifics, Medicaid, and the Medicare savings programs. We really welcome your, asking questions and sharing your experiences. Yesterday, we went in and talked a lot about, state systems. There wasn't a lot of opportunity to relate that information to how it might impact an individual. We were just kind of giving you information. But this is going to be different. We're going to talk about things that happen in people's lives and why maybe one pathway to Medicaid could be advantageous to another pathway to Medicaid. And so you may have experienced some of these things as well in the people that you've worked with in the past. So feel free to jump in, and if you have questions or want to share, we totally welcome that. So this is our agenda. We're going to do just a real quick overview, medical overview. We're going to go into then Medicare savings plans and full benefit dual eligible. Just a little bit of time in both of those sections. And then we're really going to spend the majority of the time in Medicaid. We're going to do an overview. We're going to look at scope of care and long-term support services. We're going to look at eligibility and the waiver, and then some additional programs and information. Let's start off with the overview. So this slide is really just showing you what you already know. It's showing you that there are certain medical benefits that are connected to Social Security cash benefits. So Title II benefits, that's disability insurance, child to disability benefits, disabled widows or widowers benefits, and retirement insurance benefits, all from Social Security. The medical associated with those programs is Medicare. And then Title 16, SSI, which is Supplemental Security Income, the medical that we associate with that is Medicaid. And I think you all know that. Now, it's important to know that there's other ways that people can qualify for Medicaid. In Washington State, if you have SSI, you automatically qualify for Medicaid, but it's not the only way that you can qualify for Medicaid. So we'll be talking about that.
Can I just say, though, Scott, that the reason Scott says in Washington State, you automatically qualify for Medicaid is because that's not the case in every state. There are some states, less states than those that do the automatic, but there are some states where you either have to go down the street and apply and bring your SSI, or there is an entirely separate process that people go through in order, even if they're on SSI, to get Medicaid. So that's why he differentiated. It's not the case in every state. States have to basically contract with Social Security to do that automated process.
Yeah, thanks, Susan. So a person who is not receiving those cash benefits may still be eligible for Medicare or Medicaid. And some of these examples. So for example, with Medicare, there is the extended Medicare coverage. A person could have been receiving Title II benefits, they were performing SGA, and their cash benefits stopped. But there's that extended period of time where their Medicare continues. So they aren't necessarily receiving a cash benefit, and yet they remain eligible for Medicare. And then there's also the Medicare buy-in, which is a possibility for folks after that extended Medicare coverage ends. And then in terms of Medicaid, well, we know of a few. There's 1619B, and just we'll talk a little bit more about this, but just as a refresher, when people are working and they're receiving SSI, if their wages cause their SSI to go down to zero, they may remain eligible for Medicaid through 1619B, as long as they would otherwise remain eligible for SSI and they follow all the same rules. They have less than $2,000 in the bank, they report their income, etc. But it's a way that you can see people are actually making so much money that they stop receiving a cash benefit, but they maintain their Medicaid. And then there's some other ones, Apple Health for workers with disabilities, where people have the ability to purchase Medicaid. They don't necessarily have to have a cash benefit to qualify for that program. There's what's called special income level with the waivers, adult Medicaid. We're going to look into all of these. So just want to give you a heads up that even though we generally think of these medical programs being connected to a cash benefit, sometimes people don't have to receive that cash benefit to actually qualify.
No, but the framework,
Yes.
these other benefits, tends to rely heavily on SSI calculations and
Right.
rules. So the $2,000 resource limit, that's obvious. But there's also income calculations that allow for exclusions of certain programs, and those exclusions look a lot like what you see with SSI. And it's because all of those rules are still based on SSI, low income / means tested rules for the most part. And if they're not, they have to specifically cite that exclusion when it's an SSI disability related Medicaid program. So you'll find that no matter what, SSI is sort of casting um, light into those programs in terms of, I was going to say shadows, but light into those programs to kind of define eligibility.
That's right. That's so well put. Okay. So in case you don't know this, it's okay to have Medicare and Medicaid and actually private insurance as well all at the same time. I know that people have concerns about that. So it is okay to have all three. Medicaid is the payer of last resort. Typically, if a person was to go into the doctor and the doctor took all three, private insurance, Medicare, and Medicaid, that is the order that they would typically bill for. They bill the private insurance first, then Medicare, and then Medicaid. Now, if someone's working at a smaller company, the insurance may actually bill Medicare first and then the private insurance. The doctor, excuse me, that's how the billing would work and that's how it would get coordinated. But in regards to this slide, I think once people have private insurance and maybe if they have Medicare, sometimes people will say, well, I guess I don't need my Medicaid anymore, right? Because they think I already have this really good insurance. And what they don't realize is that the Medicaid may be paying for all kinds of things in their life that they need. For example, in-home supports or employment supports. Or maybe by having Medicaid, the person doesn't have to pay for their Medicare Part B premium. I mean, there's all kinds of benefits to having Medicaid that a lot of times I find that individuals and families just aren't aware of. And so as we talk today about Medicaid, and we talk about the waivers and some other long-term support services, it'll become clear about why Medicaid it can be so important for people as they try to live in their communities.
I also want to mention that sometimes people will say the opposite. I have Medicaid, so I'm not going to use my employer's insurance because I have to pay a premium.
Right.
And we talked about premium payment program. So first of all, that's not necessarily a concern. But do you remember when we were talking about SSI and unemployment and how actually the rules say you're supposed to apply for any other program for which you may be eligible? And that exists in the Medicaid programs for people with disabilities as well, that Medicaid is supposed to be the payer of last resort, and people are supposed to, although my experience is it's not tracked really, but people are supposed to apply for the other programs for which they might be eligible. So it's one of those things where it really isn't an option if it's made available to someone, and yet it's probably not going to be noticed if they don't enroll in their employer's program. But I strongly encourage people to do it for more than just the reason I just gave you, but also because they may be able to have access to a broader array of medical doctors and other kinds of treatments and services through private insurance than they would through Medicare or Medicaid, because not all doctors take Medicare or Medicaid, but you have a plethora of options typically within a private insurance program. So in order to have Medicaid to cover those specialty services that insurance typically wouldn't cover, it's good for people to keep that. But on the other end of it, it is also really good and expands options for people to retain private insurance as well. And this is a very common conversation I have with people. It comes up a lot.
Mm-hmm. Yeah. Any questions about this? Okay. All right, let's jump into Medicare savings plans and the full benefit dual eligible folks. So what is the Medicare Savings Program? That program, which we call MSP, it can provide assistance to Medicare eligible individuals with, for example, their premium costs or co-payments, deductibles, and also co-insurance. And so in Washington State, Medicaid recipients typically are automatically enrolled in a Medicare savings program, and they don't need to apply. And we see that with people who are low income as well, who may not have Medicaid. So I think more often than not, with the people that you're going to be working with, who are clients of DDA, you'll find that if they do have Medicare, they may have already been enrolled in a Medicare savings program. So just as a heads up. And so we're not going to spend a huge amount of time on these programs for that reason. However, if you have questions around MSP, and we're going to go over just a little bit in the next slide, there's this desk aid that's actually really pretty helpful. And I'm going to click on this. And I'm going to actually, hold on a second. I have to bring it in like, hold on a second. This is updated regularly. So this was updated in April of this year. But it's a really good reference guide on everything you'd ever want to know about Medicare savings programs. It goes to each of the programs. It gives these codes, which we call ACEs codes. Super helpful. I find that with Medicare savings programs, I'm not always on top of it because, again, so many people that I work with they're already enrolled in one of these savings programs. But if you ever need to reference it in terms of the services that are covered or what the income or resource limits are, this is a really good handout. And this is up on the website for you. Come back to here. Now, if you are working with a customer and they're not Medicaid eligible, they can apply online for a Medicare savings plan by going to washingtonconnection.org. We introduced that yesterday. They can also submit a paper application, and you can go to this link to get that application. And if people want more information that the customers you're working with about MSPs, there's a brochure here that people can click on. Now, this screen here is basically a summary of some of the information that's on that one pager that I just showed you. And I don't think we're going to go into all of this information because it's a little overwhelming. But a couple of things I want to point out. And by the way, all of these figures here are for a single person. You may have heard of these savings plans and not necessarily known what they were. Like you may have heard or seen QMB or SLMB. You know, those are pretty common. And those are types of Medicare savings plans. And if someone's eligible for, say, QMB, it means they have income that's below 100% of the federal poverty level, which in 2020 is $1,064. And they have to have resources that are less than $7,860. And if someone's eligible under QMB, that means their Part A premiums, Part B premiums, co-insurance deductibles, and Part B co-payments are paid for. If someone doesn't fall into that category, but they fall in this other category, you know, maybe their income is just a little bit higher, they could qualify for, they could qualify for SLMB, and it works that way all the way down. Each category that a person may fall in covers a different type of certain differences around what it actually pays for in terms of a person's premiums. But what I want to point out here is this state buy-in. So if someone is not eligible for these QMB, SLMB, QI1 and QDWI, if they're not eligible for those, but they have Medicaid, so the person has Medicaid and Medicare at the same time, they still qualify for a Medicare savings plan. And if they qualify, so as long as they have Medicaid, they would qualify. And it would pay for their Part B premiums, co-insurance, and deductibles. May not have a resource limit either, because if someone's qualified for Medicaid in a way that there is no resource limit for that Medicaid, then they would qualify and they could have unlimited money and be eligible for this MSP.
But if they qualified for a program where there was a resource limit, like I don't know, SSI, right?
Yeah.
$2,000 resource limit, and it conveys to that Medicaid program that's linked to that SSI eligibility. Obviously, they do have a limit, but they don't measure it in these Medicare savings plans. It's measured in the Medicaid program.
Yep. Exactly.
I think one of the questions I had pretty early on when I was looking at this is, well, how do people know which one they want to be in? And it's like, well, it's about, for instance, the difference between QMB and SlimB, QMB and SLMB. You can see there's a shift in how much you can have for income. So if somebody exceeds that $1,064 income limit, then they could roll to the SLMB with a $1,276 limit, or 120% of the federal poverty level. So a piece of the work is to take a look at this, and usually they apply, they're going to be enrolled in a program. It's going to be based on income and resources and other factors. But you can look at this and tell people what the limit for the program that they're in is for the existing year. And I, like Scott, have troubles tracking these things. They're odd numbers, very different than any of the Medicaid stuff that we work in. And I find myself having to go and look in order to pinpoint exactly what I need to tell somebody about the limit for the program that they're in.
Right. So this is in regards to the prescription drug plan, which is Part D of Medicare, and full benefit dual eligible, meaning that the person is eligible for Medicare and Medicaid. So CMS, the Center for Medicare and Medicaid Services, they automatically enroll all dual eligible individuals and MSP individuals into a Part D plan. So if someone's a little worried about that, maybe someone's on Medicaid, they happen to be on Title II benefits as well, and they're going to be approaching that time where they're going to be signing up for Medicare. They'll actually get enrolled automatically in a Part D plan because that person has Medicaid. So they would have Medicaid and Medicare, and they would just automatically get enrolled in a Part D plan. Now, that Part D plan may not be the best plan for them. So I always tell people that, still do the work of just looking at the available prescription drug plans and choose the one that is best for you. But if they didn't do that and they're with a plan, for whatever reason they didn't like it, maybe there was some issue with geographically, they wanted to choose a different drug plan. People who are dual eligible or they're eligible for the MSP, they can change to a different Part D plan any month if they choose, which is different than other people who say just get Medicare. Those people often can't change their drug plan until the next annual period when they can make those changes. But if someone has Medicaid and Medicare, or they're just they're low income and they qualify for a Medicare savings program, they can change their Part D plan anytime they want. Something else, if a person is residing in an institution or they're eligible for a home and community-based waiver, they are exempt from paying their Part D copayments. And Susan, is that just for DDA waivers, or is that for both waivers? Do you know about that?
I think I know it applies to DDA waivers.
Right.
I'm not sure about COPEs. I would assume that it's the same, but I would have to look.
Me too.
Yeah.
But we can definitely confirm for the DDA waivers. So when you're working with folks who may be eligible for the DDA waiver, they're exempt from having to pay their Part D copayments. And then lastly, Medicaid will continue to cover some drugs that are not covered in Part D, including certain over-the-counter medications. So if someone has Medicaid and Medicare, they're going to be using the Part D to pay for their prescription drugs. But if there's some things that they need that they can't get covered under that plan, Medicaid will typically cover those costs. Susan, is there anything you want to add to this slide?
No.
Okay.
I wonder if there are any questions about this part. All right.
I'm going over this fairly quickly because, again, I think a lot of people we meet with, they're already on a plan. But it's good just to have this information and be familiar with it and know the resources that are available if you want to answer those questions, just as Susan was talking about. Okay, so now we're going to do a Medicaid overview, and this is going to be, Susan, you start on this section. So you just tell me when to change the slide.
Okay.
And I'll do that.
Go ahead. So I think I alluded to this yesterday, that Medicaid is actually a partnership between states and the federal government. So in order to enter into that partnership where the federal government is going to reimburse some of the costs that the state pays for otherwise, the states are required to do certain things as they're part of that partnership. They're required to cover certain mandatory services as well as certain mandatory eligibility groups. And there's this body of state plan services that the federal government identifies as the Medicaid state plan services that states must provide in terms of the service. So they have mandatory services that are defined in the state plan. They have mandatory eligibility groups, and then the federal government agrees to match what the state spends by at least 50%. And in recent years, Washington state has tended to stay somewhere between 50 and 55% for the most part over the years. And it's based on factors within that state that help the federal government gauge how much to pay. I think that some states were getting something approaching 75% in the days where it was just this one kind of match amount. And then in recent years, with the Affordable Care Act and other things that have happened, there has been enhanced match. Yesterday, we talked about an enhanced match for states that entered into an agreement with the Centers for Medicare and Medicaid during this pandemic period, where the states that were entering into that enhanced match agreement were required to maintain Medicaid during the pandemic emergency period for certain eligibility groups. So that's an example of where the match is higher as a result of entering into that special agreement with the Centers for Medicare and Medicaid. Next slide. So there are pieces of Medicaid services in states that are state crafted. So Medicaid eligibility and processes can be different from state to state. I mentioned earlier that Washington is a 1634A state. I didn't use that term, but I did say that people who are on SSI are automatically eligible for Medicaid in that state. And Social Security is the entity that reviews that eligibility. They tell the state who it is that they have found to be eligible as an SSI recipient, either through cash SSI benefits or in 1619B status, where they have that extended eligibility for Medicaid beyond when they get an SSI payment. The federal government, SSA, tells states about those groups of people if a state is a 1634A state. They've entered into that agreement. States can also offer optional services to other eligibility groups. And one of those optional services would be our Medicaid buy-in. It could be a Medicaid waiver. And if you travel around the United States, when you look at Medicaid programs for these special eligibility groups or offering enhanced services, they differ vastly. So if I were to hop the border and go to Oregon, I have to take a look at what the state has built or crafted for their other Medicaid programs. The only thing that is really predictable is what the federal government requires for all Medicaid recipients in that state plan. Everything else can be quite different, and states apply to the federal government and get approval to offer those additional optional services to various eligibility groups. In Washington state, Apple Health is the brand name for Medicaid now. So many of us who have been associated with benefits planning for years and years have had to make the adjustment of understanding that people will refer to these Medicaid programs as Apple Health.
Susan, yes. On Sunday, I was talking to a parent of someone who receives Medicaid, and she said, "Oh, my son gets Apple Health," and I said, "Oh, he gets Medicaid." She said, "No, he doesn't qualify for Medicaid. He qualifies for Apple Health." And it's just, it's just one of those things.
Really confusing.
It's confusing, yeah.
Was this a parent that has been around for a while supporting their son or daughter? Was it because of the transition that they were confused?
I didn't get into it, but I wouldn't be surprised. And then, it's also confusing when you have the card for Medicaid and it says provider one. We talked about that yesterday. So you have these different terms for generally the same thing.
Yeah. It seems like it's never easy. I guess we wouldn't need to do benefits planning if it was, I suppose. It's right. Just all work. Next slide. So Medicaid programs are means tested, and means tested means that income and resources may be considered. And, that there's a certain low income standard in general that needs to be met in order for someone to be Medicaid eligible. And again, a lot of those rules around income and resources are defined through SSI rules. So it's very similar for the most part. It does not mean that all Medicaid programs are have the same rules, but if they don't have the same rules, they have to call it out. So income and resources are always called out across these programs in terms of how you meet the eligibility standards for those programs.
Yeah.
Next slide. So for Medicaid for people with disabilities, there's also this functional criteria that comes into place where you have to meet disability criteria. And that in general means that you have to meet the SSI definition of disability or the SSI definition for blindness. And for people that aren't on Social Security benefits, where there may have been a determination that they had a disability that met those requirements, they have to be determined eligible through a process that is a non-grant medical assistance program. And it goes through the exact same folks. In fact, they just recently had a question about this. Somebody was applying for Medicaid, and they apparently hadn't provided enough information to support that they had a disability that qualified. So even though the person knew they wouldn't be eligible for Social Security, they thought, well, maybe I'll apply for Social Security and they will determine eligibility and then everything will be fine, even if they say I'm not eligible for cash benefits. And I had to explain to them that it is the exact same state office, our Disability Determination Services office, that determines eligibility under a contract with Social Security based on Social Security's disability definition. And they also determine eligibility for any non-grant medical assistance program. And so it wouldn't matter. They would still have the same office determining disability. The most important thing is for people to be able to clearly provide information that from medical sources, from other sources, that supports that they have a disability that meets the Social Security definition. There are some examples that are in that link that's at the bottom that you can click on and look at. I think that one of the examples that is really readily available that we can call on is our Medicaid buy-in program, where people would typically, well, they might not typically be eligible for Social Security, but they could be eligible for our Medicaid buy-in, and they would apply, they would go through a disability determination process, and that would be considered in terms of their eligibility for that program.
After you go through the this entire training, I think going into these NGMA examples will make more sense, and is useful to check out, because you will run into situations where it helps to get some clarification about the direction a person will need to go to qualify for Medicaid.
Next slide.
Okay, scope of care and long-term support services. It's 10 o'clock. Susan, how do you feel about me continuing, or do you think we need to do a little break?
I'm thinking maybe we could get through this piece, and then when we get to the piece where we look at the table, we could take a break. Does that sound okay to you?
Get to the table. Sure. Yeah. Well, and people can just holler if they need if they need a moment. Sounds good.
I'm shooting for about maybe 10:30.
Okay, sounds good. That sounds great. Let me go back to this slide. So actually, hold on a second. We're going to be talking in this section around both scope of care and long-term support services. And this is the beginning of creating a foundation of understanding some of the terminology around Medicaid and understanding different eligibility groups for Medicaid and services that it covers. And then from this place, we're going to be looking at pathways to Medicaid eligibility. So we just have to kind of push through this section. So if anyone has any questions though along the way, please feel free to ask. Okay, just stop me and ask. So when we're talking about scope of care, and you may have seen this term before as it relates to Medicaid, scope of care refers to the medical and healthcare services that an Apple Health program covers. And there are essentially 4 categories. And what I'm going to do here is I'm going to start from the right and then go to the left. Or actually, I'm going to bounce around a little bit. And then the next slide, you'll see why I put these in the following order. So categorically needy Medicaid, that actually, when someone has what's called CN, or categorically needy Medicaid, the scope of care with that particular Medicaid is the broadest and most comprehensive. And so if someone has SSI, for example, they get C in Medicaid. But there's other ways that people can qualify for C in Medicaid. And again, that provides the most comprehensive medical and health care. Now, there's another type of Medicaid scope of care called Alternate Benefits Plan, or ABP. So someone might have a Medicaid and it might be called ABP. It happens to cover the same medical and health care as categorically needy. But it's available for people through the Apple Health for Adults program. So we also call that MAGI or adult medical. These are people, and it's not just for those individuals, but these are people who do not necessarily need to have a disability to qualify for Apple Health. And they may qualify for this ABP Apple Health, which has a scope of care which is identical to the categorically needy. Medical care services, we don't see this a lot for folks who are DDA eligible, and it actually covers the least amount of care services of all of these 4. And it's available to adults who don't qualify for those other scopes of care on this page, but they happen to meet the eligibility criteria for the aged, blind, disabled, and or the housing and essential needs programs. Now, you may have seen those programs in the other work that you do. We don't see a lot of people who are DDA eligible using ABD or HEND, although they certainly could. So if someone did not qualify for Medicaid with these other types of scope of cares, but they were eligible for ABD or HEND, they could qualify for the MCS scope of care Medicaid. And then lastly, there's medically needy. And that covers not as much as categorically needy in terms of its health care, but more than the MCS. So that might be a little bit confusing, but wanted to give you that information because chances are you've heard people talk about, oh, I get medically needy Medicaid, or I have categorically needy Medicaid, and not really understood what those meant. And they refer to the scope of care. But now let's take a look at long-term support services. Now, this slide won't make a tremendous amount of sense because we haven't talked yet about long-term support services, but we're going to right after this. But I want you just to have an idea here about what's going on with those scopes of care and the long-term support services they cover. So if you look down here in this box, we have different icons for these different types of services. So medical coverage is what we were talking about in that last slide. But then these other types of programs, such as Medicaid personal care, or community first choice, a person can qualify for one or the other, and it can pay for, say, in-home supports. CFC may pay for some additional things like assistive technology. And then there's this thing called the waiver, which we're going to be talking about at length. These are home and community-based services waivers, and they may pay for things such as like employment supports. So if you come here and look at the medically needy Medicaid, if someone came to you and they had Medicaid and you found out that it was the MN scope of care Medicaid, what does it cover? Well, it's going to cover some medical costs. It doesn't cover as much medical costs as categorically needy, as we saw that in the last slide. And that's about it. It just covers the medical costs. But then what if you're working with someone who needed in-home supports? Then you would want to consider how could they move from this particular Medicaid to a Medicaid that has a different scope of care to cover those services. So for example, if someone's in this medical care services, the MCS scope of care, they get medical services. It's actually the least complete compared to the other medical services covered by these programs. But a person could also qualify for Medicaid personal care for in-home supports. Or if a person was eligible for this ABP, alternate benefits plan Medicaid, they could qualify for medical, MPC, but they also could potentially qualify for CFC, community first choice, which can provide in-home supports like MPC plus some additional services. And then lastly, categorically needy, you can see it's the big tree here on the right. It covers everything. Medical, the best medical of the bunch, really. Medicaid personal care, it covers CFC, and it can cover the waiver. So to bring this all together, when people are eligible for categorically needy Medicaid, there's more options to pay for the services that they may need in their life. Now, not everyone needs to have this, but my experience is that for the people that we're working with who are DDA eligible, if they are eligible for Medicaid, it tends to be the categorically needy because they need these services in their life. And if they're not eligible for it, it may be that they could benefit from those services. Occasionally we see people who are eligible for medically needy and we decide, it would make a lot more sense if you came over here to categorically needy so you could get some in-home supports that you need or maybe some job supports. So this slide is really just to create kind of a foundation. And then what we're going to do is go into these and talk a little bit more about what these services are. And then we'll go into greater detail about the waiver. So before I continue, I'm wondering if anyone has any questions about that.
Scott?
Yes.
Angela, I got a question. I guess most people, they just kind of know if they've got Medicaid. So is this something you would chat with a case manager about, or who would usually furnish you with this information?
Yeah, it's a really good question. First, whoops, sorry. I don't know what's going on here. First of all, what we're hoping to do, so we are wanting to collect information from the state when people come in to benefit you requesting benefits planning services. Our hope is to have them sign a release and we can get information, and we could find that information from the state, ideally before you begin working with the individual. So we would know right away if they were under M in Medicaid or C in Medicaid or ADP. That is one way. You could probably get it from a case manager. I'm assuming they could see that information on the screen, but I can't confirm that. Sometimes you can find out just by talking to the individual. You know, if someone says, I get Medicaid and, you know, I have a job coach that's paid for, and my dad gets paid to help me out in the home. Well, chances are they're going to be eligible for categorically needy Medicaid. And Susan, what do you think? Are there some other ways that people might be able to find out about this?
Well, I certainly have sometimes gotten clues by what somebody is telling me that I can ascertain which program they got into. They can describe certain things that lead me to, I don't want to get into the weeds too much about this, but it can lead me to what kind of program is framed, you know, their services are framed around. But you can get an ACES code. You can kind of start to dig into what the ACES code is what the state uses. You can dig into what the person gets by pinpointing the coding that the state uses for the program they're in. And really, I think a large part of our focus is going to be, okay, we may know where somebody is, but it doesn't mean they have to stay there.
Yeah.
We could help them apply for other programs. And there are two pieces of application. One is that the person is going to have to be functionally eligible. There's going to be a functional assessment of their need, and the program that they're in is going to be defined around that. And then there's this financial assessment of where they are. So what program are they qualified for financially? And so those two pieces kind of go together. And as we do benefits planning, we tend to look towards both. And the financial piece and trying to get them to the right program tends to be a bit easier than the functional process, because then we're asking for someone to do an assessment of their level of care need in order to be eligible for the program. And if we're trying to move somebody, that's when we may be interacting with case managers about them doing their piece of the process or what they've collected or those kinds of things. And it's really well beyond our control. The financial piece, a lot of the time we can produce strategies that help somebody meet the financial requirements, like using work incentives can help somebody. Helping them find a program that actually better meets their financial needs. A lot of the time, that's what a benefit planner really needs to do, because a case resource manager at DDA is unlikely to be able to figure that piece out. So there, obviously, people can apply and be determined eligible financially, but sometimes we need to give them the strategies and tools to be able to meet that criteria. So that's a lot of where we focus is, yeah, you know where somebody is, but we're in their lives determining their needs as well as potential work incentives that might apply.
Right.
Hopefully I didn't get too far off track there, Angela, in talking about that.
No, that was helpful. Thank you both.
About 6 months ago, I was working with an individual who the case manager reached out to me, and the DDA case manager, and said, yeah, this person has come off the waiver, and they didn't know why. So, you know, sometimes the case managers just don't have a certain level of information around how some of these things work around Medicaid and the rules around Medicaid. So I went out and met with the individual, and you know, it was just sort of a mystery. Why does this person not have Medicaid? And then he gave me a letter, and it said that he was eligible for medically needy Medicaid. But he could have qualified for categorically needy. It was an error. I think it was an error actually that the state had made. They moved him from categorically needy to medically needy. So we just had to go in there and do a new application for the Apple Health for Workers with Disabilities. And then he switched back over to categorically needy. But that does happen, right? So that person suddenly just lost their in-home supports and employment supports and became eligible for this medically needy Medicaid. And they just didn't know that they just had to go through an application and apply specifically for the Apple Health for Workers with Disabilities program to be able to qualify. That doesn't happen very often. because usually the state will put the person on the Medicaid that's the most advantageous for them, but you do see it from time and time again.
You know, and they're actually required to.
Yeah.
They're required to look for the program that meets the person's needs. And if there is a program that is offered at lower cost to the individual or provides more of what the individual needs, they're required to do that. But people are people, and systems even sometimes end up with programming glitches that cause problems. And benefit planners working at the front line with people to try to figure these things out are often the first ones to see that there's an issue. So those are things where if we encounter what seems to be a pattern of problems, then we'll communicate with state folks about that issue to see if there's a way for somebody to look into it and resolve it. But Scott's right, that typically doesn't happen, but those are the kinds of situations, even if they don't typically happen, that tend to come to us. So we're acutely aware that it is happening, at least to some degree.
Right. And then Cynthia asked, let's see here, is there a list of what each of these supports provides? And I guess, Cynthia, you're referring to like what all does MPC cover, what does CFC cover, the waiver? Yes, and we're going to be going through, we'll be talking more about these programs. This is really just sort of creating just a foundation to understand how scope of care and long-term supports work. We'll be going into more detail. Okay. Does anyone have any other questions? Otherwise, I'll move on. Okay. Whoops. So let's focus on these long-term support services now. And long-term support services, they're Medicaid funded supports. And let's take a look at this chart to talk about them. And then we're going to go into each one of these in a little bit more detail. So when we talk about long-term support services, there's a few different options here. There's Medicaid personal care, which we talked about in that last slide, community first choice, and the home and community-based waivers. And you see this dotted line here between Medicaid personal care and community first choice. That's there for a couple of reasons. One is that a person cannot have Medicaid personal care and community first choice at the same time. You can have one or the other, but not both. But also, if someone is eligible for a waiver, they can qualify also for community first choice, but they cannot qualify for Medicaid personal care. For the people who are DDA eligible and who are receiving services, they typically fall in this area of community first choice and or home community-based waivers. In the next slide, we're going to go in and talk about just sort of the differences between MPC and CFC, and then we'll go into the waivers. Now, who determines eligibility for these programs? Well, there's a functional assessment, as Susan mentioned, and we'll talk a little bit more about that in a little bit. And then services have to be authorized as well. If someone's a client of DDAs, then the DDA would do the functional assessment. If someone's a client of home and community services, then typically it's home and community services who would do that particular assessment for eligibility for these programs. Now, I'm just talking about
that can be confusing, Scott, because, I talked about the disability determination services determining disability, right?
Yes.
And so it's a multi-level kind of functional assessment. That's the thing I want you to keep in mind, is that DDA and home and community services are looking more closely at, okay, what are the nuances to this program for functional assessment beyond just having a disability? And they're the ones that determine that. Do they really have a need for services within their home and community that are expanded, for instance, because of their level of care need? So they dig a little deeper than just, does the person have a disability that qualifies under the Social Security rules? So that would be part one. The second thing is that this dotted line between Medicaid personal care and community first choice, it makes it sound like somebody in community first choice couldn't get personal care, but they can. they get it through the Community First Choice program. So they don't need access to a whole separate program for personal care. They are covered under the umbrella of Community First Choice. If they need personal care, they're going to be able to get it through Community First Choice. So there's no need for this add-on of Medicaid personal care. That separate program to the far left of Medicaid personal care is for people that would otherwise not qualify for personal care under Community First Choice, but they still have the need for that service. So that's the reason that it's sort of clustered under a whole separate program, is that it's a standalone rather than a wraparound like Community First Choice.
And most people I see, Susan, if they're eligible for in-home services, it's coming through Community First Choice, not Medicaid personal care.
Yeah, me too.
Yeah. We'll be talking a little bit more about this functional assessment. But let's take a look about just the differences between these. So this does a little bit of a comparison of Medicaid personal care, Medicaid personal care and Community First Choice. So for Medicaid personal care, it's for individuals who do not meet an institutional level of care. And I'll talk about that in just a little bit more in a second. And it provides personal care and in-home assistance with activities of daily living. So if people need assistance with, with dressing or bathing and that type of assistance. And as we talked about earlier, it cannot be combined with a waiver. So Medicaid personal care is really just focused on the person receiving support, either in their home or in, maybe they're living in, say, an adult family home or another type of alternate living facility. They can receive Medicaid personal care in those settings. Now, Community First Choice provides similar services, but it's for individuals who meet an institutional level of care. And when we talk about institutional level of care, so let's say that the person is DDA eligible. The DDA case resource manager, they do a functional assessment and they determine if the person would need the level of care that is provided in an institution or an intermediate care facility. And if the answer is yes, then they would meet this institutional level of care. And if they have that level of care and they have a need for in-home support services, and that could be in their own home or if they're living in an alternate living facility, then through Community First Choice, they can receive that personal care. As also, they can receive assistive technology, skills acquisition training. They can get this personal emergency response systems, which means it's essentially some basic technology to help them if they're in an emergency, etc. And Community First Choice can be combined with a waiver. So if you compare these two, Community First Choice is actually, it's a much better program than Medicaid personal care. And I don't know how long ago it was, Susan, when Community First Choice basically kind of came into being, and a lot of the people ended up switching over from Medicaid personal care over to Community First Choice. Do you remember that?
I think maybe 5 or 6 years ago.
Yeah.
States began to have this option for K services, is what they call it, under Part K in the section of rules that apply to Medicaid programs. And so states would apply to the federal government and say what they wanted to do. And in this service arena, they got an additional enhanced match. So in our state, for instance, with people on the waiver, it became a financial incentive for the state to break out those services into Community First Choice under the Part K option in order to get that enhanced match, and the person would still receive the services. So that's when that sort of splintering or cutting out some of the services and clustering them under Community First Choice happened. I think it's been about 5 years. It was an adjustment. Yeah. It was an adjustment for all of us because all of a sudden, as benefits planners, for instance, you had to learn to be able to learn enough to be able to convey what was happening to people, that they were going to get this additional package of services that might have previously been provided under the waiver, but now were provided under this new Community First Choice program.
Yeah. And in all those efforts, I think the majority of the people were transferred over to Community First Choice. I don't think you're going to be working with a lot of people who just get Medicaid personal care. It could happen, but it's not going to be super common. So we're just coming back to this screen. And now what we want to do is look at these home and community-based waivers. And it's 10:24. I want to kind of be sensitive to the time because the next few slides are on the waivers. What do you think, Susan? Should I just keep going, get through this section?
Are you guys ready for a break, or do you want to finish this and then stop in about, it's probably about 10 minutes.
10 minutes. Oh, Alana Cooper's making a comment.
Yeah, you saw a lot of that splintering off in behavioral health, I would imagine.
Yeah.
So, yeah.
Yep. Well, how about if we'll just push through this then, and then we'll take a little bit of a break. We can do that. Okay. Thanks for letting me. We have another chat here. I can go 10 minutes more. Okay, we're in it. Okay, so let's take a look at the waivers. Another term for the waivers is we can call it long-term care. And you see here on the left, as we talked about, you can become eligible for a waiver to be a client of DDAs and qualify for a waiver. You can be a client of home and community services and potentially qualify for the waiver. And long-term care services are for the aged and disabled in need of an institutional level of care. That's what we talked about just in that last slide. And so these long-term care services are commonly provided through these waivers. And let me talk a little bit about what it means when we talk about a waiver. So a person is eligible, once they go through this functional assessment, it's determined that they're eligible to receive services in an institutional setting. But what they're doing is they're waiving their right to living in an institution, and instead they're saying, I want to live in the community and receive the same or similar services. So when we talk about the waiver, they're waiving their right to live in an institution and choosing to live in the community. And to live in the community, they're going to receive supports to help them be as independent as possible. And that's what we talk about when we talk about the waiver. These waivers are authorized either by DDA or Home and Community Services, just like I just mentioned. But it's important to know that the waivers are very different between those two programs. So if I'm on a waiver through DDA, it might look very different than a waiver that I get through Home and Community Services in terms of maybe the services that it covers and in terms of the financial eligibility, potentially.
The reason for that is because states have to apply to provide these special services that are beyond the state plan services. They have to apply to the Centers for Medicare and Medicaid. They have to propose what services they'd provide to what eligibility group. And then there is also this added piece that is performed, which is that the federal government determines whether it would represent a cost savings to serve this group of people with these services in the community instead of in an institution. So every time that we want to add an eligibility group, you add an eligibility group and you propose the services. And then additionally, it needs to represent a cost savings over the institutional setting. The other thing that I would say is when I've had people ask me, why waivers? Why do we need to do that? And it really dates back to the late 70s when it became clear that we were spending a lot of money on people being institutionalized. And it was because families, individuals and families, couldn't get all of the wraparound services like support in a living situation, plus the medical, plus any additional services that a person might need beyond the state plan, unless they put their loved one in an institution. And so it was considered to be an institutional bias, that it automatically directed people to need to go to the institution to get that level of care. And so it was introduced as an option to allow people who wanted to live in their communities and work in their communities potentially to be able to get that same level of care and a packet of services that ordinarily they would have had to go to the institution to get. So that's really the foundation for how waivers came into being.
So DDA waivers. It's important to know that most DDA services are through the waiver. And DDA has 5 different waivers. There's the Children's Intensive In-Home Behavioral Support Waiver. That is, that's family-centered, and it's a wraparound service, as Susan described. It's only available to individuals age 18 to 21, typically for youth who engage in aggressive behaviors that put them at risk of out-of-home placement. There's the Individual and Family Services Waiver, which a person may be eligible for as early as age 3. And that also tends to focus on supporting families who have a family member with a developmental disability. Then we have these other waivers: Basic Plus, Core, and Community Protection. And let's see, Core waiver, in comparison to the Basic Plus waiver, Core waiver tends to have a residential component. Would you agree with that, Susan? The difference between Core and Basic Plus is that if someone's in a residential program, they would be on the Core waiver.
In general, yes.
In general, yeah.
Much more, you know, it's a more robust package.
Yeah, it's a more robust, right, package of services. And then there's community protection. And so community protection are, if someone's in the community protection program within DDA, it means they are at risk to either their own health or to other people in the community. And so, for example, if someone committed arson, they might be in the community protection program. So people who are in the community protection waiver have a unique sense of services that they need. They may need someone to be watching them at all times when they're out in the community. So the services there look different than maybe some of these other waivers. As we talked about earlier, a person eligible for the waiver can also be eligible for community first choice. That's common. So when you see someone who's on the waiver, they often have these in-home supports, and that's through community first choice. There are some people who are eligible for DDA, but they qualify for the COPES waiver through Home and Community Services, but that's not very common. But just a heads up, that does happen. And something else I just want to say, you know, there's a lot of DDA eligible individuals who are not on a waiver. There are, gosh, Susan, I don't know the numbers off the top of my head, but I would say it's likely in the thousands of people who are not currently receiving services in DDA.
Yeah, I wonder if Angela knows with her association with the ARC of Washington State.
Yes, Angela, do you have any insight on that?
I don't know the exact number right off the top of my head. That'd be something maybe Diana or something would know. I could email her and get a number later today, probably.
Yeah,
I'm curious about that. But so if someone, okay, let me talk about this a little bit. Someone may have become eligible for DDA when they were young, and maybe they did a reassessment at age 18, but they've never really pursued services. They could be eligible for DDA, but not receiving anything. In fact, if they're not getting any services, they're not even getting a case manager. They're just part of this no services caseload that's out there. Now, they may not qualify for a waiver, or maybe they could, but they haven't necessarily pursued it. So there are a lot of people who are clients of DDA, but just are not eligible for the waiver or other services, including a case manager.
and I think people often wonder why, and it in part has to do with capitating costs. Because waiver services, even with the federal match, cost the states some money.
Right.
States make a determination based on their budget about what they can provide, what can be available. And really right now in our budget discussions, there's discussion about changing the eligibility for the waivers in order to decrease the number of people that would be in that program, be eligible for that program, because states can define what is eligibility for the functional side of things for the waiver programs.
Mm-hmm.
So states go through processes to try to contain costs, and that leaves some people without those services. In Washington, one of the things that happens is that there is more of a priority given to people getting on the waiver if they are employed. So in the description that Scott's talking about, where somebody may start quite young on the waiver, let's say they're getting on the individual and family services waiver, for instance, and they may get a variety of services. As they reach adulthood, it may be that they still need waiver services, but trying to get them in the door for, let's say, the Basic Plus waiver, one of the crucial pieces is to try to achieve employment, because then they become a priority for getting those services in place to help support them in maintaining that job long term.
Right.
And those services are contained in those Basic Plus core community protection waivers.
Mm-hmm.
So you'll sometimes be involved in conversations if we're working with younger people that are referred to you about how are they going to be able to elevate their capability, not their capability, but the consideration for them being eligible for in entering into a waiver. And employment is a critical component for a lot of people.
Yep. Yep. Oops. And this particular slide here, it just kind of gives, this is just a snapshot of the different types of services that the waiver offers and what's covered under each waiver. And what you can see visually here is that not every waiver type covers all the services. So for example, they break down the services between 4 categories: community services, professional services, caregiving, and goods and services. So let's start at the top here and look at supported employment. That's for a person who needs employment supports, long-term employment supports typically. So what we might see is that a person signs up for DVR, and DVR funds an employment agency to help someone find a job and get stable in that job. But if that person needs ongoing support to remain successful in that job, then they would need the supported employment service through the DDA waiver. Now, they could, if they're on the Basic Plus waiver or the core waiver or the community protection waiver, they can qualify for those long-term supports around employment. But you notice that IFS waiver is not there. So if someone is eligible for the IFS waiver, but they needed job services, job employment services, they would need to, job coaching services, they would need to switch waivers and go from IFS to one of these other waivers, which is available for people. People can move to another waiver as their needs change. If you look at community inclusion is a program where it helps people build community connections and explore interests in their community. And that's available for people who are Basic Plus or core only. Not available for community protection or not available for IFS waiver. And so this is just gives you an example visually of the things that are available to different waivers. If you click on this box at the bottom here, the Home and Community Services and DDA Service Comparison Chart, it will list, in fact, I'm going to do that right now. Can you see that? It lists, so here's all the DDA waivers. It looks Basic Plus, Core, Community Protection, SIBS, IFS. Then it goes on to Home and Community Services waivers. And you can look at the different types of service here and what's covered under each program if you really want to get to that level. And I don't know if it's that necessary for you to get to that level, because the case managers usually, they do an assessment on these on an annual basis and try to put them into the waiver that would best meet their needs. But in case you have any questions about that, this chart is really helpful. Susan, is there anything you want to add? Oh, sorry, I just lost my slide. Is there anything that you want to add to that particular screen that I just lost?
No.
Okay, let's see. Oh, so Tracy said there are currently 829 people with developmental disabilities waiting for waiver services in Washington. But then she said, Tracy, you said that you believe it's over 5,000. I think those are two different figures. I mean, obviously they're different figures, but they're measuring two different things.
Right.
So,
one is waiting, and the other is overall unpaid services caseload, I think.
right. Yeah, exactly. Does anyone have any questions about these waivers and the services that they may or may not cover, any of that kind of information? Is this making sense to folks?
This is Susan. This information is really great. This is the first time I'm hearing it. On this slide, is it possible with the waiver, just because I'm new at this, the B plus, the C and all of that, I know we just went over it, but can we put like a key below just to make it a quick, easy reference?
Yes. In fact, I had that originally, excuse me, but I took it off because I wondered if it was too busy. And so I can just move it up into this section and we could save it on the website.
Great, thanks.
Yeah.
And you know, the thing I like about this chart, this is one that Scott developed for this, is that you can see what the state proposed to provide to the federal government, because that's really what those examples are. Like where in community services, person-centered planning isn't a part of the overall body of services. You can see it in individual and family support, and you go, oh, the state applied with that as a part of the package of services that they wanted approval to provide. Therapeutic equipment and supplies, you can see that there's only one place where that applies. Well, that really does help you to begin to understand that there's a variety of things that states propose, and sometimes in certain packages they'll provide certain services, and yet in another package offered by the state they won't propose that service. I do want to say that just because person-centered planning isn't called out under supported employment or community inclusion does not mean that it isn't a part of what can be provided in the course of providing supported employment services.
Right.
So there are other ways that the state has gotten to that service without needing to call it out separately.
Mm-hmm. Yeah, that's a good point, Susan.
At age 3, Juan is accepted into Head Start, a birth to 3 program supporting children with delays and their families. Juan has been diagnosed as having a developmental disability. Staff at Head Start share that there is a program that supports families called the Developmental Disabilities Administration. Juan applies and becomes eligible. The DDA Case Resource Manager determines that the family is eligible for the Individual and Family Support Waiver. This waiver provides Juan and his family with behavioral support and consultation, speech therapy, specialized medical equipment and supplies, and respite. Throughout his childhood, Juan attends a school in his community. At age 18, Juan walked with his classmates in his graduation ceremony, but stays in school through its transition program, which helps him gain life skills and try out work in community settings. His family hears about Social Security and Juan applies. He qualifies for SSI. During this time, his DDA Case Resource Manager suggests that Juan look at what services he might need and be eligible to receive for the rest of his adulthood, receiving supports at work and in the community. He is told that he would be a priority to move to a different waiver that aligns with his goals if he leaves school with a job. While in transition, Juan reaches out to a benefits planner to ask what will happen to his Social Security benefits when offered a job. He receives assurance that he can work and remain eligible for SSI and Medicaid. As Juan nears 21, he gets a job and reconnects with the DDA Case Resource Manager. Juan is determined eligible for a Basic Plus waiver. Under this waiver, he receives funded employment supports and assistive technology to help him be more independent. He also receives personal care at home. Juan is now 24. The state just increased the minimum wage by 75 cents per hour. Juan's mom is worried about the loss of SSI and the waiver. Juan meets with a benefits planner and is assured that even if SSI is reduced to $0 due to wages, he will remain eligible for Medicaid and therefore keep his waiver. At age 27, Juan continues to work but is getting tired of shuffling his money to stay below the $2,000 resource limit. He meets with a benefits planner and chooses to go over the resource limit as a strategy to leave 1619B status so that he can move to HWD with no resource limit. Moving off 1619B means Juan is leaving his SSI eligibility, but he is prepared to make this transition thanks to the help of his benefits planner. Juan enrolls in HWD, maintains his waiver, and can now easily save money.
Okay, so the reason that Scott and I kind of pulled that video together, or actually pulled the script together and had our staff at WISE pull it together, is because we thought that it would be nice to represent some kind of an example of the way that people can maintain eligibility and move to different programs, as well as the benefit of a benefits planner in that process. It's pretty brief. It's just one example, but we thought that it might be useful not only when we're talking with people about Medicaid eligibility and training people like you, but also trying to get that information to individuals and families. So we just thought this would be a good time to debut it and to get your feedback about it, and whether you think that that story helps to kind of cover those bases.
Yeah, I think it's great.
Thank you.
I think it definitely shows that you can move down the path and still maintain those benefits and continue to work. So it's exciting.
Thank you, Alana. I see your chat.
I love the graphics and illustration. I thought it just weaved together a really nice story, and I really like the way it was presented.
Well, thank you. You know, the one question I was asking and looking at it is, why was that person karate chopping their keyboard when they were typing in the information? It amused me. I thought that was so funny, that particular graphic.
Susan, this is Scott. One of the things I like about this, and I know we actually put together the script, but it's pretty common, right? I think that trajectory that someone's on, we see that a lot. Someone gets into DDA when they're young. They start off on a particular waiver, in this case, the IFS waiver. And then they go into transition with school. They get a job. They move over to the Basic Plus waiver to pay for their long-term supports. And then as they get to a place where they're, making more money and wanting to save money, they start looking at different options and different ways to qualify for Medicaid that will best meet their needs. So it's I don't know, when I watched that animation, I realized, yeah, that happens a lot with the folks that we serve.
It does. Yeah. Scott, this is Susan. You'll probably get to this soon, but I'm just curious, is it possible, or how often does it happen when you find somebody who's in one waiver who really needs to be in another one, but that other waiver is capped out or there's a wait list? Does that happen?
It does. Particularly, let's say if their parents are aging and they need to get more residential supports in a different setting, like they're living with their parents, that it can be tricky to get somebody onto a different DDA waiver. Like they're already waiver eligible and they're in the Basic Plus waiver, trying to get them into the core waiver can be tricky for a variety of reasons. Trying to find a residential setting that works for the individual, meets their needs, is one piece of it. And then also the thing about having sort of capitated costs that make it challenging to try to figure out how to meet that need. However, those are, again, priority situations where we know that the person may be at risk of institutionalization, for instance, if they don't get the services that they need in the community. It sort of elevates the attention to that situation and trying to figure it out.
Yeah.
So, need to move is going to be based on urgency in part, and employment is one of those urgent situations, but residential situations is another area where it could be really important. Same is true for community protection.
Yeah.
Somebody, if they need community protection services in order to be in the community because of, something that puts the community or the individual at risk in a significant way, then they're elevated in priority to get into that package of service or onto that waiver that provides the services that they need. So we're going to dig in a little deeper into eligibility and the waiver. And they're sort of clustered together because what you're going to see is that Medicaid eligibility is one component, and then waiver eligibility is sort of an additional layer. So when we talk about Medicaid eligibility, and we also are incorporating in information about the waiver, we want to show you what eligibility groups actually qualify for the waiver and which ones don't. So we're going to cover them all in sort of one fell swoop, specifically focused primarily on people with developmental disabilities. So we're talking about, there are a lot of Medicaid programs. We're talking about the ones that you're most likely to touch on in the work that you do with the population that we're serving initially and benefit you. Next slide. So there are a variety of Medicaid eligibility pathways. We've talked about SSI and 1619B, where anybody on SSI is on Medicaid. If they lose that SSI cash benefit, there's also that extended Medicaid offered through 1619B. In recent years, we've added a group, the adult Medicaid group, that is based on the modified adjusted gross income, or MAGI income level. This came about through the Affordable Care Act, and it isn't specific to a person with a disability. However, sometimes it is a good way to get somebody into Medicaid if they are waiting to be able to get into some other Medicaid pathway, or if they're waiting for Medicare. So let's say I'm driving down the road and I get into an accident, and as a result of that accident, I have significant issues, and I apply for Social Security, and in fact, I might even receive SSDI, but I'm waiting that 24 months after I first get cash benefits for Medicare. I could apply for this adult Medicaid, and based on my modified adjusted gross income, the bottom line on my tax return, I may well be able to become eligible for Medicaid without any kind of a determination of disability, even just in order to be able to meet my medical needs while I'm waiting for Medicare. So that's become a kind of interesting and great option in a lot of circumstances where we find that people are waiting for some reason for medical coverage to kick in. We also have Apple Health for Workers with Disabilities, which is our Medicaid buy-in program. It came about as a result of the Ticket to Work legislation back, 20 years ago, almost. And it allows people who are working to be able to access Medicaid, and they pay a premium for that coverage, but it allows them to have Medicaid be available to them as their income and resources continue to rise. And then we have home and community-based waivers. And it's so interesting that we list that as sort of a separate group. But there's really one separate group primarily for people with developmental disabilities that comes just through home and community-based waivers. And we're going to talk about that one financial eligibility group. But a variety of these other groups also meet the requirements for financial eligibility for home and community-based waivers. So we're gonna take a good look at that here coming up. The key thing about this is that the way that earnings and resources may affect a person's Medicaid eligibility all depends on what eligibility group they're in. So we are often trying to pull out the right tool, the right group that will help somebody maintain their eligibility. As Scott mentioned, the state goes through a process of determining what group somebody belongs in. And in fact, they're required, if somebody loses eligibility in one group, to try to figure out what other group the person might fit into. But you can imagine how confusing that would be to individuals and families to like have somebody do something and say, oh, here's the group that you're in, without really having the individual have the opportunity to kind of strategize about what group do they want to be in, which one actually best meets their needs, and how can they get themselves positioned to slide into the group that would be the preferred group for them, which is a primary role of benefits planning, along with us trying to resolve issues that may come about where there's been a mistake that has been made, like the kind of situation that Scott talked about, where somebody lost eligibility in one group and it landed in a group that was way less favorable and did not provide the services they need. Understanding these different pathways allowed Scott to be able to go into that situation and help the person to address it. Ordinarily on this slide, when we're presenting to community members, we say it is not your role to understand all of these. But in this situation, because you're doing benefits planning with individuals, it is your role to understand these. And it doesn't mean that you have to know them all of the time. It just means that when somebody is really facing issues with Medicaid, it is your role to sort it out and get the information, all of the information that you can, to help them make a good informed choice and get to what they need. Next slide. Again, if eligibility is lost in one pathway, the state must consider other pathways. They usually are taking a look at services and cost. So they have to look to the pathway that offers the most beneficial program to that individual at the lowest cost. And eligibility for any Medicaid program is redetermined once every 12 months in alignment with what Social Security does for people on SSI, where they review income and resources every 12 months. The state does that for those that aren't made eligible for Medicaid by SSI eligibility as well. So you'll see people have to go through and provide information about income and resources in order to remain eligible, and that happens once every 12 months.
Susan, I'm going to ask you just a quick question. Can you see my this bar up at the top, the Zoom bar in this recording that lists mute, start video participants?
No.
Okay, good. I just wanted to make sure before I continued. Okay.
So we talked earlier on today about trying to figure out what program somebody is in. In our Department of Social and Health Services, DSHS, has an online system that integrates information and provides codes for the person's eligibility for the benefits and programs that they receive. And this is a list of some of the most common ACES codes. So SO1, people that are SSI recipients, they would have the code, ACES code SO1, for instance. People who are on our Medicaid buy-in would have SO8 as an ACES code for our Apple Health for workers with disabilities. People that are in home and community-based services programs, what you would see is more of a code that indicates those long-term care services like L21 or L22. Scott and I, when we were looking at this, we were talking about how the letter that precedes the number gives you an indication as well, like the S being either SSI recipients or SSI related. The L being long-term care kinds of things, typically, even if the person is SSI related. The N that is before the Affordable Care Act, adult Medicaid option, non-grant medical. That's where they still have to meet the definitions sometimes set forth in other ways, but they don't have to do all of the things that are typical with somebody that's associated with Social Security. So non-grant medical is one of those things I think of when I see an N. So when you're looking at these codes, keep in mind that they give you a clue about what Medicaid pathway somebody is on, and sometimes really pinpoint exactly where the person comes in and how they achieved eligibility financially and sometimes functionally for the program.
Yeah, I like, Susan, how you describe it as a clue, because this can feel kind of overwhelming to look at these, and these are just some of the ACEs codes. There's actually many more, but it's really just being able to, once you understand a person's code, we can get that information from the state, you can immediately go in and figure out what their situation is. Like, oh, SO1, okay, that's an SSI recipient. It gives you a lot of information. So it's less critical to, say, memorize these than it is just to know that this is like a map. When you get an ACEs code, it's going to tell you a lot of information about the person's medical situation.
All right, next slide.
And one more thing, this website here will take folks to all the different ACEs codes.
Do you want to click on it just so that they get a chance to see what you're talking about with all of the various codes?
Yeah, can you see that screen?
Yep.
Okay. Here are actually some of the ones that we were just talking about, SSI and SSI related, SO1, SO2. But if you just scroll down, it gets quite lengthy. There's G codes, here's the L codes, keeps on going down, there's K codes, quite a few. But again, this is something not to fear. If you find out someone's L22, you just find it and you say, oh, okay. And this may not make immediate sense at this moment, but we think it will by the end of the training. You'll have a pretty good understanding about what the financial rules for this person's eligibility for Medicaid and the waiver. Okay.
I have to say that if for some reason we don't have the code when you get the referral, you can talk with a case resource manager and ask them for that. Mm-hmm. Our hope is to have a flow of information between state agencies and our call center so that we can access that information much more readily. But we're building the system, and a piece of that is really hammering out an agreement to allow us to get all of the information that would be readily available to provide to you so that you have a much more full picture without having to go through individualized contacts. But you could talk with a systems person, somebody within a state agency, to get that code as well.
Yep. Okay.
So this chart is actually set up to just provide you with a snapshot of the basic information around eligibility, who fits into these different groups, and what services are provided. So it's usually on legal size paper. It's gotten that big. It's funny because I think when I created this maybe almost 20 years ago, that it was really just a letter-sized piece of paper and one-sided, and now it's actually a legal-sized piece of paper and two-sided, with the first side being the most common programs that people with developmental disabilities may access, and the other side being more about home and community services programs. So the first page, DDA, second page, home and community services. And just in looking at the chart, the way that I did this is to provide the Medicaid pathways in the boxes, the yellow and blue boxes, and then to be able to have a green bar across those boxes that also would provide the individual with the financial eligibility for the waivers. And I really want to emphasize financial eligibility because people still have to have a functional eligibility determination to determine if they get waiver services. Do they need those services because they meet the institutional level of care? They could otherwise be in an institution to receive the services, and they're waiving that to get those services in the community. So this chart really just speaks to financially, if somebody is in a particular group, have they already been able to check the box that yes, they financially would be eligible for the waiver? So that green bar only goes over or covers 3 of the boxes, doesn't cover the other 2. So that means that you can assume if somebody is in one of those other 2 boxes on the far left of this page, that they aren't eligible financially for the waiver, at least not right now. The upper corner represents all of the financial thresholds for people. So, you can drill down into what is the 1619B threshold for the year. You can look at what the SSI federal benefit rate is for the year, which some of the eligibility groups are based on. You can see the resource limits. It gives you an opportunity to see those financial dollars-based pieces that these eligibility groups are based around.
Susan, when you were talking about this, it's what we talked about earlier about the different scopes of care, what they cover. You can see that reflected here because we talked about the medically needy really just covering medical, but not covering the waivers. And you can see that green bar doesn't extend here. And the same was for the Medicaid for modified adjusted gross income, not covering the waivers. And this chart, by the way, is, when Susan put this together, I used it all the time. It's really, really helpful just to keep these, to keep this information straight. It's really clear, and it's amazing that she was able to capture all this information on one page. So it's definitely something that you want to have handy.
Well, really what I did is I took the rules and looked at all of the different areas. And back in the days when I created this originally, it was really hard to find all of this. And then I took it to our healthcare authority. It wasn't called healthcare authority back then, but to the Medicaid management, state agency, as well as to Lori Raleigh within the Aging and Long-Term Services Administration, to make sure that what I had really painted the right picture and that I was accurate. And it's evolved over time, but I do think that it really helps you be able to explain things to people as well as to understand it yourself, because it's super confusing. So we're going to go through all of these basic areas, and then we're going to do some calculations and some examples to show you how they work. But this in and of itself will be a standalone thing that you can print up and hang on to. You can, when you're talking with people, you can provide them with the information so that they also can look at it. So it's a tool that you might find useful in your work as well. All right, so next slide, Scott. Here we go. All right, so the first one is the eligible for SSI. It's categorically needy coverage group. And what services are provided within this group are access to personal care, Eligibility for the waiver services if somebody is functionally eligible, and that state Medicaid coverage that states are required to provide as a part of their primary Medicaid package. And we put the ACEs codes in here for you to look to when you're thinking about this. So if you see L21, that would be somebody that is on home and community-based services. SO1 means that the person is SSI eligible, or SO2 means that they're SSI related. So we're going to drill down a little bit into SSI related. What does that mean? You could see that the income standards are that the person have a categorically needy income level, or they are under the 1619B, either the standard threshold or an individualized threshold that you ask be set based on the person having extraordinary Medicaid costs. But we use the SSA standards, and we also use the SSA formula for SSI that gives you all of those exclusions that people typically would get in SSI. So the $20 general exclusion, the 65.5 additional earned income exclusions, those exclusions along with IRWIs and PASs and other things can apply in order to reduce the countable income that a person has for this program. And we're going to take you through that, but it's going to look super familiar to you because you got that in your initial certification training. There are some other people, though, that fit into this group. So people who receive SSI, yes, in 1619A, 1619B, but there are certain people that are called DACs, Disabled Adult Children, or now the SSI label for that is Childhood Disability Beneficiaries. There are certain people that get that benefit off of a parent's record who also get a special exclusion to be able to qualify for Medicaid. And the rules as we go through it is it's really in a nutshell that the person, okay, they've got a childhood disability benefit, but they first had SSI. And because of receipt of a benefit on a parent's record, they lost SSI cash benefits. They have to have been over 18 when they were on SSI, and the cause of the loss of that SSI cash benefit was a benefit from a parent's record. So if they meet that criteria, we can exclude the whole benefit that they get off of the parent's record when we think about Medicaid eligibility. And we'll show you that in calculations as well. But that is definitely a benefit for people and allows them to remain in this group. There's also the pickles. Do you guys remember the pickles discussion from your initial training? Yes, no?
It's been a while.
Yeah, okay. Okay, so let me just talk about it briefly. Pickles are people who are on SSDI and SSI. So they're on SSI, they come into SSDI benefits, and the cost of living increases in their SSDI cause them to become ineligible for SSI. And it's kind of a complex group because you have to go to a table to determine the year at which they became eligible and figure out sort of a multiplier for how much would be excluded for Medicaid purposes. And then you take that how much and you are able to deduct it from their income. It's excludable from their income. And then on the bottom piece of that is you compare the remaining income after all of the regular SSI exclusions and the pickle exclusion to determine if their income falls below the SSI FBR amount. So you're going to see this calculation be pretty typical, where you're taking the person's income and you're excluding the 20 and 65 and a half and IRWs and passes and whatever else are work incentives in there. But these other exclusions are layered in there as an opportunity for somebody to not have to count that income. And then they compare the remaining countable income to the SSI federal benefit rate to determine, do they meet the income eligibility for this group? So that's really how it works. The resource limit of this group remains at $2,000, which more times than not becomes an issue for people who are working and starting to achieve higher income levels. It can also be an issue for people that get Title II benefits, as well as a variety of other folks that were low income previously. And as they begin to achieve higher income levels, this savings thing becomes a nightmare. And sometimes people just get tired of trying to figure out how to protect their income from counting it as a resource as they retain it and save it, and trying to shuffle it into ABLE or into other places to be able to stay eligible. In this group, personal care is available, and you can see at the top that eligibility for a home and community-based waiver, a DDA home and community-based waiver, or other home and community-based waivers is also a possibility for the person if they're found to meet the level of care need for the waiver. So this brings a big, robust package of potential services for someone.
You know, Susan, I find it curious that they call this category eligible for SSI, even though someone may not be receiving a cash benefit for SSI, right?
Yeah.
And qualify for Medicaid.
Yeah, and there's SSI related. People use a variety of terms for these things. SSI related, considered eligible for SSI. So it's really just clustered under this label, but that doesn't mean it's the only label that you're going to see for it.
Right. Okay, so let's take a look at the calculations now. This is the calculation tool that we're going to use to determine if the person qualifies under this categorically needy income level. And then we're going to go through a couple of equations. Situations and the equations. But first, let's just kind of go through these step by step. So categorically needy income level, again, is equivalent to the amount of the federal benefit rate, the FBR. So for this year, that would be $783. That's what a person could get for a full SSI check. That's the figure we're talking about when trying to calculate towards the categorically needy income level. And so using this tool, you can enter the person's unearned income, for example, a Social Security check. You could enter their earned income from a job. The areas that are grayed out, there's no calculation in those boxes under those columns. And you can kind of go through and end up with a figure. And if it's below the categorically needy income level, then it means the person could qualify under that category. So let's look at these row by row. So first of all, you would exclude the person's DAC, or child to disability benefit, if the benefit previously reduced some or all of the person's SSI. And I'm repeating what Susan already talked about earlier, but this is something that we see that happens fairly often. Someone's on SSI, and then a parent either dies or retires. That's what we may see commonly. And then they get this benefit check that knocks them off of SSI. According to this calculation sheet, we could take that benefit amount and exclude it. So we could exclude it in this particular box. We can also exclude increases in the SSDI if the person was previously a concurrent beneficiary. So what we mean here is just what Susan was talking about with PICL. If someone is getting SSI and SSDI at the same time, concurrent beneficiary, and then the SSDI increases due to cost of living, it might knock the person off of SSI cash benefit, but they may still qualify for Medicaid. You can put that information in this calculation and see if the person could qualify. We'll talk a little bit more about that. So you make those exclusions to determine what is the remaining unearned income. And then you come into these calculations, which you are probably pretty comfortable with for people who are on SSI. So you apply a $20 general exclusion to their unearned income. If they don't have any unearned income, you would apply it to their earned income. You would apply a $65 earned income exclusion, subtract any IRWs, divide the remaining amount by 2, subtract any blind work expenses, and then you come up with the total. So you would add up your total of earned income, the total of unearned income, and then you could compare that to the categorically needy income level, which is 783 this year. And if it's below that figure, then they would be considered eligible for SSI for these purposes. So let's go through a couple of examples. I think it will become more clear. So here's FAM, and FAM received SSI, and she is on the waiver, and her mother just retired. So she became eligible for $1,000 in CDB benefits. And it was so large that it kicked her off of the SSI cash benefit program. So what is going to happen to her waiver? Well, the waiver is a Medicaid program. She was getting Medicaid through that SSI category. Let's see what happens to that $1,000 and if it affects her waiver eligibility. So we entered her information here. She gets $1,000 in her childhood disability benefit, and she also happens to get $1,205 from a job. So let's do the calculation. So the first thing we do is ask the question, did she lose her SSI by receiving a childhood disability benefit? And the answer is yes, it kicked her off the SSI cash benefit. So we can actually exclude that entire $1,000 for this calculation purposes. So even though she gets $1,000 in childhood disability benefits, on paper, for this purpose of determining Medicaid eligibility, it looks like she has no unearned income. So then you just follow the normal calculations that you would do with earned income. So you subtract $20, you subtract $65, so it's the general exclusion and the earned income exclusions, brings us down to $1,120. We're not aware of her having any IRWs, so we just move on to the next step. We take that 1,120 and divide it by 2, that equals 560. We add up her unearned, which is 0, to her earned, which is 560, and it looks like her countable income for this purpose is $560, which is less than 783. That means she's eligible for Medicaid under this categorically income level for that particular chart. So let me show you, go back to this right here. So she was eligible for SSI. She became eligible for a childhood disability benefit, but after we excluded it and took a look at her earned income, she still remained below this categorically needy income level. And so she still remains eligible for Medicaid and the waiver under this particular pathway. Does that make sense to folks?
I want to mention the reason that we retain that term DAC, disabled adult child, which is an old term, right? CDB has taken over now in the Social Security world for that benefit type. We retain that DAC label because this is really known, has been historically known as the DAC exclusion. So in the Medicaid world, you're going to see DAC exclusion used a lot. So that's one subtlety that I wanted to talk about. And the second one is that the person has to have been on SSI as an adult. So let's say that somebody gets a benefit off of a parent's record as a child, a dependent child under the age of 18, like dad has died and they're getting a benefit off of dad's record, and they roll right into adulthood with the childhood disability benefit being the converted benefit from their minor child's benefit to a disability benefit when they're over the age of 18. they don't qualify for this exclusion. So there are some subtleties to this that you have to keep in mind when you're thinking about whether that exclusion is going to apply or not for the person.
Yeah, and that's exactly in this calculation here. Laya's dad died when she was 7. She became eligible for childhood disability benefits when she turned age 18, but she had never received SSI. So we can't exclude the childhood disability benefit here. In which case we look at her earned income and her unearned income and her earned income, excuse me. And when you do the entire calculation, she actually ends up above 783, and she's not eligible for Medicaid through that one financial eligibility pathway. We do see that. I do see that a fair amount, actually, Susan. You know, someone's parent has died when they were under the age of 18.
Me too. And I actually have people ask me questions like, well, I don't know that we really need SSI. I don't think we're going to apply. We can cover the cost for our child. And one of the things that I tell people about is this exclusion for Medicaid, and that you don't know what's going to happen with parents as somebody, you know, gets older, as the individual with disabilities grows into their adulthood, and that getting on SSI early is kind of a preventative tactic for Medicaid protection. That getting into SSI as soon as a person turns 18 or shortly thereafter will allow them to enjoy this protection if a parent decides to retire or they become disabled or they die. That the individual would be able to utilize that exclusion in the Medicaid world.
Yeah, that's good advice to give folks. I want to show you a little bit of this calculation because it will lead into this next slide. So we can't exclude this childhood disability benefit of $800. That's what Laya is getting from her dad. And so we come down here, we're going to apply the $20 general exclusion like we normally would if someone had unearned income. Makes that look like $780. Then we start looking at her earned income, and she's not working very much. She's only making $105 in the month gross. That's what she's receiving. So you apply the exclusions. You apply the $65 exclusion, which brings us down to $40. We didn't ask about any early, so we just hit not applicable here. And then we take 40 divided by 2, that equals 20. So for her earned income, the amount that we're going to count for this calculation is just $20 of it. And then for her unearned income, we're going to count $780 of it. We add those together, and it just pushes her over the 783. So she's not eligible for Medicaid under that financial pathway. Now, whoops, let's go this way. Let's take a look here, because this is a tactic that you may want to use. She is so close to this limit that maybe she does have it early. Maybe you hadn't had the opportunity to talk to her. Does she have any impairment-related work expenses? Because if she does, it doesn't need to be very big here to get her to go below the $783. And it's the same for the blind work expense. Does she have a blind work expense? Was that worked into the calculation? It could also work for PASS. If she were to have a PASS, even though it's not part of this calculation, you essentially take the money that causes her SSI to go down to zero. You could put that into a PASS in a separate account through an approved PASS plan, and in return she could qualify for SSI and Medicaid. But I just want to point out that someone may not have an early, and if they develop an early, it may protect their Medicaid under one particular financial eligibility pathway for that Medicaid program. And you may then want to explore that, help them develop those earlies, get them established, and then it may bring the person down below the categorically needy income level so they can qualify for Medicaid.
Scott, I have a question. This is Susan. So while you're waiting for the early to be approved and using this scenario, what would happen? Because the person does not qualify, but we're still waiting on the early to be approved.
Yeah, that's a good question. We're going to be looking at some other eligibility pathways, which they could then bounce over to. if they meet the eligibility requirements. But Susan, I'm wondering, have you had any luck in submitting an IRWI to the state if it has not yet been approved by Social Security, submitting the IRWI to the state so they can approve it more immediately? Yeah.
Yes. And actually those long-term care specialty units have been they've been established to help us work through some of these pieces. It used to be that the state didn't really have a good way of trying to assure that there was a connection to these work incentives. I mean, they were in rule, but it was sometimes hard to get them to be applied. So I have people that are trained to be able to spot them. And it really will be the state for somebody that isn't truly on SSI. It will be the state that makes the decision. I was going to actually point out, Susan, that when we talk about PASS, you have to remember that actually with PASS, what happens is that the person actually bounces back into SSI eligibility. So you don't see PASS like called out on this chart. It's just an aside comment to say the person would be in categorically needy Medicaid because they would become an SSI recipient if a PASS was approved. So because they would be putting their countable unearned and earned income into a PASS, which would mean if the income falls below 783, that they would be eligible for SSI. So a lot of this is maneuvering around eligibility groups, sometimes within one category, one pathway, or sometimes finding another pathway if it seems like you're hitting some issues with the state or the federal government recognizing a work incentive so that the person can continue to receive coverage while we're waiting.
Yeah. It seems to me that it didn't used to always be so easy. So it seems it's great that you can actually reach out to a DDA financial worker, provide the information about an IRWI, and get it approved, right? For their purposes of determining Medicaid eligibility.
Yes. And I have to say that I think that benefits planning was integral in influencing that. That the awareness about benefits planning and everything that could be done and various strategies that could be applied helped the state to understand the need to figure out a way for these things to be considered in a more effective manner. So, I really am pleased that people are doing benefits planning, not just because individuals need the information, but because we do influence systems when we are doing our work and they can see that they need to figure out a more effective manner of getting to the answer or applying the information at the state level.
Yeah. And this just kind of captures some of the work incentive strategies for identifying, say, IRWIs or PASSes. Someone may need job coaching services or attendant care to get ready for work or even to return home. Maybe they have a reduced fare bus pass. Those could all potentially count as IRWIs. Or if someone wanted to write a PASS plan, they could do it for job exploration, just to determine what their work goal is going to be, or maybe they want to increase their work hours or pay, go to school. Those are all strategies. And, the people that you work with just may not have any information about IRWIs and PASS. And then once you present this to them, it sort of opens up a conversation. It's like, oh, I am paying for this. This would qualify as an IRWI. Or, I could really benefit from that if I paid for that out of pocket. And how would it benefit me? And that's the same with PASS. So just something, once you start looking into these, I find that you tend to uncover all kinds of possibilities for IRWIs or PASS plans.
Yeah, and just because a service is covered right now by Medicaid, because Medicaid is the payer of last resort, you could convert part of or all of the cost of a service to the individual's impairment-related work expense in order to benefit them. So there will be times that somebody gets, let's say, job coaching that's covered under their waiver program. But we know that if they paid for a little bit of that service themselves, that it would help them maintain Medicaid eligibility. So we go through a process of saying, hey, they're going to pay $200 a month of their own job coaching services in order to maintain Medicaid eligibilities, and the Medicaid system then wouldn't cover that piece. And I've done that quite a lot over the years, where it's not just job coaching, but personal care services that apply to helping them with work, getting to work, returning home, eating lunch, using the restroom, a variety of things that might be a Medicaid personal care covered service. We will work through how much could they pay on their own to the benefit of them staying eligible for Medicaid.
Yeah.
And we just communicate that to the state.
Yep. And what's interesting is when you talk to people about, say, paying for their job coaching services, people are generally oftentimes open to that idea. It's like, yeah, I want to help, because they feel more independent as well, because they're paying for example, some of those services, and might even make them feel more in control of those services. So that's been a good strategy. Okay, so let's take a look at the pickle now. And then we can I think it might be a good time to take a break for lunch after we get done with pickle. And pickle, Susan, you've already described all this, and this is one of those things that's a little bit confusing. We're going to try to make it simpler to sort out here. So the pickle amendment. If an individual was entitled to both SSI and Title II benefits in a month, and then the SSI cash benefit stops due to a cost of living adjustment or a COLA to those Title II benefits, then that COLA increase may be disregarded when calculating the categorically needy income level. So Susan mentioned a pickle chart. Here is this chart. And so what you do is you plug in the month when the person's SSI terminated. It could be during a particular period, like maybe it happened in April of 2005. So you go into April of 2005, and then it leaves you this particular multiplier. You would multiply that times the person's Social Security check, say SSDI, and that would tell you the amount of the SSDI that's going to count as unearned income. And the difference between what they receive and that amount that counts as unearned income is what's excludable through pickle, if that makes sense. And I'm going to show you an example here in a moment. One of the things I want to point out is you see these boxes that are highlighted in yellow. So I actually got this chart from there's a resource online. It's not coming from Social Security. It's coming from a third party who's put it together. And when I was creating this chart, I noticed that there's nothing here for 2015. And it makes me wonder how accurate these numbers are. So I just wanted to give you a heads up that this chart exists, but the numbers may be a little bit off. I'm going to look into it and then update it if I need to.
And obviously the state has to know how to apply the percentages.
Yes.
So this is just for your information to be able to share with someone how it works. But you won't be doing the calculation for the state, quite the opposite. The state will be doing the calculation. The other thing that I wanted to mention is that OASDI, that piece right there stands for Old Age Survivor and Disability Insurance, the coverage groups, which is really Title II benefits.
Right.
And in this case, it's actually the DI benefit, because people on SSCDB, childhood disability benefits, have their own exclusions. So pickle only applies to people on SSDI who were previously on SSI.
Right. Yeah, exactly. We could even change that so it's clear. Just change that to SSDI.
Yeah.
Let's take a look at this calculator just to help. This could potentially help you if you wanted to get an understanding about if the pickle was applying or not. So let me click on this. And actually, let me pull it up. It's an Excel worksheet. And this Excel worksheet is available online for you. Okay, let me get this there. Can you all see that? Can you see that, Susan?
Scott, this is Angela. We can see it.
Okay, great. Thank you. Okay, so we've created this calculator. So basically what you can do is you could plug in the date that the person's SSI terminated. So let's say that it was April 15th, 2002. That's when their SSI got terminated because of a COLA increase. And their Title II benefit amount is currently $850. What this does is it calculates it. It goes in and finds the date of, it would fall in this range right here, between January and December of 2002, and it's only going to look at 0.695 of the Title II benefit amount, which means that when we're calculating the categorically needy income level, even though the person is receiving $850 of SSDI, for Medicaid purposes, it would only count as $590.75. The exclusion would be the difference to $259.25. So because this chart is just, it's a little overwhelming. So we put this together just to make it easy. You just have to enter the date, Title II benefit amount, and it spits out these figures. Now let's come over here to the categorically needy income level calculator. Now this happens to be the same calculator that we've been going over in this presentation. But we wanted to show you the concepts first before we just launched you into this, because I think that's really important. But let's just take a look at this particular calculator. I'm going to come back here and clear these out. You can answer these questions about the person's their situation with their earnings, Social Security, etc., and it'll plug the information into this calculator to the right, and will determine if the person is above or below the categorically needy income level. So let's say that someone had $1,000 in earnings, and they have a child to disability benefit or DAC check of $900. Now, all that information tells us that the $900 of child to disability benefits and the $1,000 of earnings makes this person well over the categorically needy income level. But did the child to disability benefit or DAC benefit previously reduce some or all of the person's SSI? And let's say the answer is yes. Let's say the person used to get SSI and then they got knocked off because of getting this DAC check. So let's change that to Y. And now this calculator will exclude that $900, just like we do in the calculator in the presentation. We're only looking at the earned income. We follow the calculation, and their income is below the categorically needy income level. So this is a resource that's available to you. It also has the pickle exclusion. If you happen to fill in the pickle information in here, it will populate this box and it'll populate this calculator. So you can get information immediately if someone qualifies for Medicaid under the categorically needy income level. What do you think? Is that something that's helpful for you all? Do you think that's going to be a useful tool for you? Tracy says,
very helpful.
Okay, great. And Susan and I were talking about, really expanding on these calculators. We're going to continue talking about waivers and eligibility pathways, and we think that this is going to just grow. We'll have lots of different calculators that you can enter in information, and it'll be a lot more, it'll kind of zero in on where the person is in terms of their Medicaid.
Yeah, if you go back to Susan's spreadsheet, especially when you look at the 2-page one, there's quite a few different categories people can fit into, in theory.
Exactly. You're talking about the entire sheet of the
entire sheet, yeah.
Yes, exactly. So the calculation sheet that we have right now only captures that categorically needy income level group. So it's going to be a bigger project, but it could be really helpful.
Yeah, that calculator is very helpful, and yeah, expanding on that would be very cool.
Okay, great.
Yeah, we're very helpful. I mean, one of the things that continues to happen as we work on presentations is that what we build for tools is going to continue to evolve. And I think, there's just levels of information that you kind of, you scrape down through various layers and eventually you land on, oh, here's another thing we could do. So I think you're going to see the development of a variety of tools just out of where we are right now and what we're developing for you to make it easier so that you'll be able to look at a variety of factors and figure out the best strategy for someone and to walk them through it. Say, oh, hey, if you just would pay for part of your job coaching, look how it's to change everything.
Right.
Or you're in this one group where you pay for some of your cost of care in your living situation. Let's compare it to where you could be if you paid a small premium and got into the Medicaid buy-in group. It would represent a cost savings. So being able to do that in an automated fashion will make it easier for you from a distance to show people on the fly how applying different strategies might be of benefit to them.
Yeah.
So, yeah.
This slide just basically shows what we were just talking about, but let's just go through it really quickly. So here's Amir, and he gets $900 of SSDI, and he lost his SSI in March of 2005 due to an SSDI COLA. So the question is he below the categorically needy income level? And I used figures from that calculator to come up with this. He is eligible for the pickle, and we would actually only look at 0.739, I guess that would be 73.9% of his SSDI. We would exclude the rest. And so even though he's getting $900 of SSDI, for this calculation purposes, his unearned income only looks like $665.10. Then we subtract the $20 exclusion as we normally would. He has no earned income, so we don't care about any of that. And we come down and he has $645 on paper of unearned income, and that's less than $783. So he actually qualifies for Medicaid under the categorically needy income level. And Susan, I actually have a question for you. Mm-hmm. Have you worked with individuals who you think qualified for the pickle, but the state didn't catch it?
If I reel back through the history of time that I've been doing this, yes, there have been periods of time where that hasn't happened so well. But again, the state is getting better and better at it.
Yes.
There's still mistakes. We see people land in the wrong group, and we are able to bring information forth that points out that something wasn't considered. But a lot of it has been automated in computer programs. It does rely on the person entering the information, putting it in the right place, though. Like yes. Putting SSDI in there in the right place, that it is SSDI, and getting the information so that it can be compared. What happens in the state Medicaid system is they compare their records to Social Security's to try to get to accurate information about what is the amount of pickle that should be applied, the pickle exclusion that should be applied. And you know how it is with Social Security. Any of you who have run BPQYs, sometimes there's a mistake there about when the person actually became eligible for SSDI, or sometimes you'll find within the state system that somebody put something in the wrong box. So you may come upon problems. I have to say, I just have not seen this happen very often, but the pickle exclusion is a pretty rare exclusion for people to use.
Yeah,
in my experience.
It truly is. And I know we're going in a lot of information about that, but on the other side of that is people hear the term pickle, but they really don't understand it. So hopefully this helps explain what that exclusion is about. And this slide basically what this does is it goes through a few different scenarios, going over what we had just talked about, the DAC exclusion, the pickle exclusion, IRWIs. So if you look at 3 different scenarios, in each one of them, the person's earning from a job $500 per month. That's what they received gross in the month. And then unearned income, this first person has $800 in DAC or CDB. This person gets $700 in SSDI, but they can use the pickle exclusion. And this person has $700 of SSDI, and they can use the pickle exclusion. So if this DAC is excludable, we don't look at the entire $800 of DAC, which means that when you do the calculation for their earned income, they're well below the categorically needy income level. It's under 783, and so they would qualify for Medicaid under that categorically needy income level. This person who has pickle, because of that can be applied since 2002, we really only want to look at $76 of that 700. So their countable SSDI for this purpose would be 624. We subtract a $20 exclusion. We follow the other exclusions that happen to the earned income. And this person happens to be a little above the categorically needy income level. So if you look to this third pathway here, it's basically the exact same situation, but then you identify some IRWs. And in this case, we identified $350 worth of impairment-related work expenses, and that's enough to get the person down below the categorically needy income level. So you can use a combination of work incentives with pickle or the DAC exclusion. All right. Okay, and I think, what do you think, Susan? I think that's a good time to take a break.
I would think so. Do you feel like we've blown your minds over this last hour?
It's a bit like going down a rabbit hole and then coming back out, because that was all in regards to this particular pathway.
And for my learning, a lot of the time I do go down a rabbit hole and get very confused and then have to go back and reapply. And it's almost like, I read a thing about brain studies and the way that people learn and make connections. And a lot of the time it feels like hitting a wall. For me personally, I've had that feeling about something complex. But it's actually, scientifically, they found that it really is your synapses are banging against each other before a new connection is made, like almost making each end of those two different pathways a little bit raw in order to join. So when you feel that experience, I found it helpful to think about it that way, like, oh, I feel like I'm banging my head up against the wall. And then it's like, I've arrived at a new connection. So just know that that's sort of one of those things that I think is a common experience. You'll probably experience. We're here to be able to walk you through it when you feel like you're hitting a wall. But again, just digging down, allowing yourself to feel that confusion, and then going back up and doing this line by line comparison, I think will be really helpful to sealing the information and making that connection in your brain.
Yeah, absolutely.
All right. Well,
Okay.
I probably is a good time for a break. I didn't see anybody say, oh, hey, I really need a break right now, but I'll just make the assumption that a break would be good. And it sounded like a half hour would work for everyone.
Mm-hmm.
So
12:40.
Go ahead. What?
Go ahead, Susan.
Yeah, 12:40 then?
Does that work for folks? Come back together at 12:40? We can take that as a yes.
Yeah. Okay.
Okay.
See you at 12:40. I'm going to stop the recording and just put everything on mute. All right. See you at 12:40. All right. It's going. Okay. So kind of we walked through this first group in some depth over the last little bit before lunch. And then we'll go ahead and continue to move through the groups. And I want to let you know that as we dig into these groups and we talk about it, that we're going to really be doing a comparison between these different pathways as well. So you'll get a chance to at least theoretically watch how somebody can move from one group to the next and what the considerations are. All right, so next slide, Scott.
There you go.
So this next group, the 300% special income level group, or SIL group, is also known as the institutional rules group in a categorically needy Medicaid program. And what that really, what this group really is about is the federal government allowed states to be able to use a special income level for people who are in these long-term services, home and community-based services waivers. So it established a potentially higher income level that people could look to for eligibility. They don't have to be eligible for a Social Security disability benefit. What they need to be eligible for is the waiver, and they need to meet the disability definition, but they don't actually have to be somebody that is on a Social Security program, and they can have a higher income level. So it's only available to people who are on a waiver. And the income level, let me just say that the ACEs code for it is L22. That's those long-term care ACEs codes. It's for people whose income is below 300% of the federal benefit rate, the SSI amount. So 3 times the 783. And if we look to that chart that we had earlier, that number this year, Scott, do you have that available? Let's see, it's 3 times 783.
Oh, yeah.
It's 2349.
Gosh, thanks.
2,349. Now, a couple of things to think about here is that because this is a special income level, that we don't go through all of the calculations around SSI with the exclusions and things like that that we did with the previous group. So it is about the gross income level, and it needs to be at or below 3 times the SSI federal benefit rate, or for 2020, $2,349. In this group, people have to be working below SGA. So keep in mind that if somebody has been working, they are on a Title II benefit, and they've worked over SGA, they've gone beyond the work incentives that are available with the on it again, off again benefit picture in that extended period of eligibility, that they would be knocked out of that categorically needy eligibility group, right? Well, they wouldn't be eligible for this group either if they have worked above SGA. So we have to remember that this group has some very specific parameters, and the eligibility is something you're going to have to pay attention to. So it's not just about that income level, it's about the ability to perform above SGA. And the people who are in this group are typically, or are people who are not considered eligible for SSA for Medicaid purposes. And the person could be working or not working. It doesn't matter. They could be either way. It also carries that resource limit of $2,000 for an individual or $3,000 for a couple. Now in this group, because it was established as a special income level for people who are on the waiver, it obviously means that they would be eligible for the DDA home and community-based services waivers. They also would be able to receive personal care, as well as a variety of other things that are available in that Community First Choice Options program, like the assistive technology and the personal emergency alert systems and things like that. Do you have anything you want to add for this slide, Scott?
Yeah, the one difference that's pretty significant between this eligibility pathway and the one that we had just talked about prior is this cost of care participation.
Oh, yes.
Which is highlighted right here. And that's why these fields are this shaded blue color to identify those folks. And we'll talk a little bit about that in just a couple slides.
I do want to say, though, that if you're looking for that provision in federal rule, it's considered to be post-eligibility cost of care. The federal government requires that individuals in certain settings who are eligible for Medicaid under some of these long-term care standards actually pay towards their cost of care. And it can be quite costly. So it's always something as a benefit planner you're going to want to look at to try to figure out, is this the best program for the person? Because just that alone, even if they're eligible through this program and, oh, yay, they're eligible for Medicaid, they're eligible for the waiver, they're on this program, the out-of-pocket cost can be pretty substantial for people. All right, next slide.
I can do this one, Susan, and then go into the next section. This is just, Susan's already described this. This is just a visual of that calculation. So unlike the more complex ones when we were talking earlier about that categorically needy income level, for this special income level, it's super straightforward. You just add up all the income, either earned or unearned and unearned, compare it to this 2,349. That's 3 times the federal benefit rate. And that's it. So you know if you're either under it or over it. So there's no DAC exclusion, no pickle exclusion. There's no minus $20 or $65 dividing by half. IRWs aren't looked at. And that's something that's, I think, easy to forget. I think people want to apply an IRWI or find a way, if someone's over this 2,349, is there some exclusion you can use here to bring the person down? But in this particular pathway, you can't. You're really just looking at their income and comparing it to a figure. Okay, so let's talk about cost of care participation. And this may be something, if you've worked with people who receive other waivers, like the COPES waiver, they also have participation rules. But those rules are going to be different than the rules we're going to be talking about here. So we're going to be focusing on those that are for people who are eligible for DDA services and eligible for Medicaid through that pathway that we're discussing right now. Before we get into it, I just want to explain some of the terminology. So ALF stands for Alternate Living Facility. The original PowerPoint that I uploaded, it said Adult Living Facility, and I just typed that incorrectly. The reason I did that is because the type of alternate living facility we typically see for people with developmental disabilities is an adult family home. So when someone lives in an adult family home, that is an example of an alternate living facility. PNA stands for Personal Needs Allowance. That's some money that the person gets to keep to pay for their clothing, personal items, and other incidentals. Room and board refers to an individual's responsibility to pay towards their food and shelter costs while living in an alternate living facility. And then lastly, participation, that's going to be their responsibility towards their personal care. So just want to lay that groundwork, and then we'll go into this a little bit. And I just want you to give you the heads up. I mean, participation is a little bit complex. So this may be something that you'll want to come back and review. And also we will look at creating a participation calculator to help with some of this information.
And again, participation is considered also to be post-eligibility cost of care.
Yeah.
So just so that you know, those two terms, they mean the same thing.
Yeah. Thanks, Susan. Okay. Let's look at people who are under this special income level category. This is the level Susan was going over, that blue box, the people who need to be under that special income level. That's why they are eligible for Medicaid and the waiver. Let's take a look at what the rules are around participation. And it depends on what their living arrangement is. So if someone is living in their own home and they're eligible for Medicaid and the waiver through that one particular pathway, the SIL pathway, their personal needs allowance, the amount that they use to pay for clothing and incidentals, et cetera, is $2,349. It's the same amount as the most that you can have in total income. It's the special income level. They also don't necessarily have a room and board cost aside from what they would just normally pay for the room and board costs. So what this essentially means is that if someone's living in their own home and they're eligible for Medicaid and the waiver under the SIL, they don't have to pay for participation because they get to keep all of their money up to that maximum $2,349 for their own, as their own personal needs allowance. Okay? But if someone is living in an alternate living facility, then the rules change. So let's say someone's living in an adult family home. Well, that person's personal needs allowance is not $2,349. It's only $70. So they get to keep $70 for themselves to pay for, some of their basic needs. And then they're required to pay for room and board. And that is established by the state. And what they do is they look at the federal benefit rate, which for this year is $783. They subtract how much they get to keep for their personal needs allowance, and that equals $713. So for this year, the cost for room and board in, say, an adult family home would be $713 per month. And that will, probably increase next year. So as the FBR increases and these figures change, you would expect to see a slight change in the room and board costs. After that, a person living in, say, an adult family home is going to have to pay the remainder of their income towards the cost of their care after certain allowable deductions. Now, I listed the deductions here, but I put the ones in blue that the ones that are the ones that we see most commonly for people who are eligible for DDA services. They will apply the earned income deduction of minus $65 from the person's earned income. And they will do that 1/2 of that remainder of earned income. And they can also subtract guardianship fees and incurred medical expenses. But after those deductions, they're going to add up that, they're going to look at the person's total income and subtract really what they get to keep for themselves, that $70 and what they're paying for room and board. And the rest of it, they're going to be paying as their cost of care participation. And that can be really significant. So, did you want to say something, Susan?
Yeah, I was going to say, I remember back when I was trying to figure all of this out in, I would say, the late 80s, I was helping people get jobs. And I didn't understand why families of individuals in group homes were saying, well, it doesn't even really matter if they work. They have to spend so much money then, so much more money for their group home that it just doesn't matter. I don't think I want them to work. And it was so frustrating to me. And I couldn't understand why some people living in the group home had to pay a lot of money based on earning money in a job and others did not. And the difference was whether they were in this special income level group or if they were in that first group that we talked about, where they were eligible for SSI or they had the DAC or pickle exclusions and the rest of their income, when you applied all of the deductions, fell under that categorically needy income level, the SSI FBR. Those folks don't have to pay this additional cost of care. They only have to pay room and board. So it became super confusing to me. And it wasn't until I started to really lay out the rules and then eventually created this chart that I clearly understood that what I was seeing is whether somebody lived in the special income level group for eligibility or if they lived in another group that allowed them to not have to pay this additional cost of care beyond room and board. So when I figured it out, I was able to help individuals and families to capitalize on getting more of their income for their own use while they were living in one of those group living kinds of situations like an adult family home or a group home. And it's super powerful to know that as a benefit planner because somebody can kind of languish there for a while and end up spending a lot of money. You could instantly save them a lot just by getting them to a different Medicaid eligibility group.
Yep. Yeah, exactly. So anytime you start working with someone who is eligible for Medicaid under the SIL and they're in, say, an adult family home or group home, that's immediately a flag, right? Because that person may have these participation costs. And then you might be wanting to look at these other pathways that we're talking about today. So let's look at an example of Teddy. So Teddy lives in an adult family home. Teddy's income, he gets $1,100 in Title II benefits. We'll say it's SSDI. And he's making a little money from a job. He's getting $455 in his earnings for a total of $1,555. He happens to have $100 in guardianship fee, pays that every month. And he's eligible for the waiver under the SIL group. So let's look at how much he has to pay for his participation. We know that he gets to keep $70. That's his personal needs allowance. We also know that he has to pay his room and board cost, which this year is $713. So now let's look at how much he needs to contribute for participation. Well, he has $1,100 in earned income. There's no deductions we can make immediately right there. Let's look at the earned income. He gets $455. Now we can subtract $65 and divide it by 2. So of the earned income, the amount that will be going towards our calculation would be $195. We're following the same type of exclusions you would do for someone who was on SSI and they had earned income. So we add this unearned income of $1,100 and $195 of earned income equals $1,295. He's going to pay $100 for his guardianship fee, and we know that that's excludable. So now it looks like his income is $1,195. We know he's going to get to keep $70 of his own. He has to pay that $713 for room and board, and everything that's remaining goes towards participation, which in this case is $412. So altogether, he gets $1,555, pays his room and board, pays $412 in participation. And then he gets to keep $430. Although of that $430, he has to take $100 and pay it towards his guardianship. So he's actually putting in his pocket only $330. Now, what's interesting is, let's say that Teddy only had unearned income and he had $1,500 of unearned income and no other earned income. After he gets to keep $70, and then he pays his room and board. And then after that, let's say he doesn't even have a guardianship fee. Pretty much the rest of that money, because there's no really other deductions he can take there, would go towards his participation. So even though he has $1,500 in Social Security, after he pays his room and board and after he pays his participation, he's going to have $70 that he gets to keep out of that. So for someone who's in a situation like that, and then they get a job and then they see a portion of the money from a job go towards participation, it's sometimes a hard sell for people living in these types of living arrangements about the benefits of work, because they're saying, if I go to work, I'm just going to lose all my money to participation. And that's a good time then to really look at, let's find maybe another pathway of eligibility for Medicaid and the waiver. Susan, is there anything you want to add to that?
Yeah, I just want to emphasize that there's eligibility for the program based on income, right? And that's that gross income amount of 3 times the SSI FBR. That's for eligibility, entryway into the group. And then for people in certain living situations, not those living at home with their parents or living in their own home, but people living in something that is considered to be an adult or an alternate living facility, like an adult family home, those people have to pay in order to pay in order to stay in those situations. And Scott's right. This really was such a disincentive. People felt like, wow, we're not really getting that much from all of our efforts to, for our son or daughter to go to work. Why would we even bother? It can be a pretty substantial disincentive.
Yeah, absolutely. Okay. This just goes back to this, and then the next slide, Susan, will go to the next one. Do you want me to move on?
Yes. Before we do, I want to ask if people have any questions so far. All righty. Okay.
Okay.
So finally, we're going to talk for waiver eligibility about Apple Health for Workers with Disabilities, HWD. Now, for years, this was not considered, actually not that many years, probably 4 or 5 after we implemented this Medicaid buy-in in the state of Washington. It did not give people eligibility for the waiver. But the state around 2008 applied to include this as a waiver eligibility group. And I have to say, I had been working on it for several years because I kept seeing people who were in that previous group having to pay so much or becoming ineligible and not being, so we couldn't keep them on the waiver and a lot of the time work through them over. And so it was so frustrating, gave me such a headache. I did the happy dance when they just simply added this group as a financial eligibility group for the waiver, because it provides a lot of opportunity for people. There's the most obvious one, which is there is no income level and there's no resource limit. So this is relatively new, the no income limit that just happened in January of this year. But that is really exciting because people don't have to worry as they make more and more money. They can pave a path to success and not worry about how much money they're making, and maintain that eligibility. And they still don't have that resource limit that has been traditional in our Apple Health for Workers with Disabilities program. The ACEs code for this group is S08. So, just keep that in mind as one of those clues that we were talking about. It does allow people not only to be eligible for waiver services, but also to be able to get personal care through our Community First Choice Options program. If somebody isn't waiver eligible, it doesn't mean they can't be part of this program because it's available for more than just people who are eligible for the waiver. It's really available for anybody with a disability who has income from work activities and meets those program rules. So when I think about who does this benefit, people who are working obviously can benefit from this and be able to take advantage of those, the lack of limits to income and resources. But it also is of benefit to people who are working and performing above SGA, because those other two groups that we talked about, there is this SGA thing that can continue to linger unless they're like 1619B folks with SSI. But for the others, they always have this SGA problem. So if they become successful at work and they perform above SGA, they would be able to move into Apple Health. When they do the determination of that eligibility for HWD, they actually ignore the SGA rules while keeping the other considerations for disability that are defined in SSI rules. There is also this thing that is super cool, which is that people in this program, their premium for HWD, the amount that they pay to stay enrolled month after month, is considered as sort of the replacement to that cost of care participation that we talked about just a few moments ago. So somebody can enter into Apple Health. Their premium will never be more than 7.5% of their total income. So that's $75 on every $1,000 that they have in income. And often it's far less. If most of their income is coming from work, not unearned income sources, the premium can be as low as 2.5%, so $25 on every 1,000. If I compare that to the cost of premiums for private insurance programs, it is a super, super low cost option. And for people that are in those group living situations like adult family homes or group homes that have been paying a lot in cost of care participation, the likelihood is the premium for HWD will save them a lot of money. Hundreds of dollars a month often can be saved. So I, as a benefit planner, knowing I had this option available for people that were on the waiver, I could talk to those parents of the individuals, if I reel back into the 80s where a parent is saying, why bother with work? They have to pay so much more money to their group home as a result. So we just don't care about work. Now I have another option that to be considered, which is, gosh, for a very low premium, they could move into this Apple Health for Workers with Disabilities program. They could stay in their adult family home or group home, and they won't have to be participating their monies, their income to the group home. They'll have to still pay room and board, but there will be no cost of care participation, just the premium.
Yeah.
I love this. I mean, it really has been so helpful.
It changes everything. I mean, before before you were able to become eligible for the waiver financially with HWD, I mean, it was much more tricky to navigate some of these things. But now, HWD is just, it can be so advantageous for people. There's no income limit. There's no resource limit. There's no cost of care participation. It's just really, it's just such a good program. So Susan already talked about this, but we'll just show you visually here. They look at two different calculations to determine the HWD premium. So the first thing they do is they would say, okay, let's do our first calculation. We're going to look at 50% of the person's unearned income that's above the SSI federal benefit rate, which is $783 for this year. Then they're going to add 5% of the person's total unearned income, and then they're going to add 2.5% of the person's earned income after a $65 deduction. That's their first calculation. Or they just look at 7.5% of the person's total income. And the HWD monthly premium will be whichever is less between the two. And Susan created this some time ago, and so this is something if you want to, cut this out of your own printed PowerPoint, but this is really handy just when you're talking to an individual or family about the HWD premium. It helps you just go through the calculations really quickly to tell them how much you think the premium would you estimate it to be. Because a lot of times when you're talking about HWD, you're kind of selling HWD if they're not on it, and you want to give them an idea about the premium to show how low it actually is. And you can pull this out and do the calculations and let them know what the cost is.
And one of the things that I find is often I can take a look and I can see that somebody has no unearned income. So I can tell them it's going to be 2.5% basically of your earned income. There's a $65 deduction, but 2.5% of your earned income. Or if they have really high unearned income plus earned income, it's going to tend to be closer to that 7.5%. So sometimes just on the fly when I'm talking with people, I can say, the most is going to be a 7.5%. It probably will be close to that because you have so much unearned income. Or all you have is earned income is going to basically be 2.5%, $25 on every 1,000 that you earn. Mm-hmm. So you get to where you can provide the information on the fly pretty easily once you get used to applying that, once you get used to telling people about it.
Yeah, exactly. So we'll just do a couple of quick examples. Here's Alicia. She receives $1,800, and that's $1,000 of SSDI and $800 in gross wages. So the first calculation, they're going to subtract $783 from the 1,000. That difference is $217, and they're going to multiply that times 0.5. That's 50% of that amount. 50% of the amount that's above the FBR, which equals $108.50. Then they're going to look at 5% of her total unearned income, which would be $1,000 times 5%, which equals $50. And then they're going to do 2.5% of her $800 of gross wages after a $65 deduction. So you take 800 minus 65 equals 735 times 2.5% equals $18.38. You add those all together, and the calculation one shows that Alicia's premium would be $176.88. Or we can look at 7.5%, just flat out 7.5% of our total income. 7.5% times 1,800 is $135. That is going to be the amount of a premium because it's lesser of the two. And that's also pre-COVID because as Susan talked about yesterday, right now there aren't monthly premiums for HWD while people are in this emergency period. Let's look at one more calculation. Here's Damien. He gets the same amount of money, 1,800 bucks. It's just wages. So there's no 50% of unearned. There's no 5% of total unearned. He doesn't get any unearned income. So all we're going to do is look at, we're going to subtract $65 from his $1,800, that deduction, and multiply that times 2.5%, which equals $43.38. Or we can look at 7.5% of his total income. And clearly, calculation one is the lower of the two, and that's the amount that he would be paying for his HWD premium. So that's what Susan was describing. If someone just has earned income, it is pretty cheap. I mean, if someone was getting $2,065 from a job, they'd only be paying $50 a month for HWD, which is amazing. And maybe someone's trying to decide if they want Medicaid or not, and do they really want to pay this premium? But you know, if they didn't have Medicaid, maybe they are also on Medicare, and they might have a Medicare Part B premium that is higher than what they'd be paying for with HWD. So you can show them that math and say, look, by buying into HWD, you're actually saving money, because otherwise you'd be paying for this Part B premium. So there's some strategies you can use there when you're talking to folks. So let's just look at Teddy again. And Susan's already talked about this, but just to kind of make this clear, we talked about Teddy. He lives in an adult family home. He has these Title II benefits of $1,100 and $455 in earnings for $1,555. There was also the information around him he has some guardianship fees. So if he's under the SIL pathway of eligibility for the waiver, he has to pay $412 for his cost of care participation, and he gets to keep $430. If Teddy were to instead move over to HWD, his premium for HWD would only be $117. So Teddy would still pay his room and board. He would also get, he'd pay his room and board, and then he'd pay his $117 for his premium for HWD, and then the rest of the money he gets to pocket. So Teddy will come out quite a bit ahead by moving over to HWD. A lot more money he gets to keep. Okay, are there any questions about this section?
This is Angela. Going back to the example of Teddy,
yep.
How is somebody put in a category like how would he have maybe been put under SIL versus choosing to go to HWD? Is it because that there wasn't a premium that he had to pay?
Yes. A lot of the time, this is where we start to see some issues with calculations and thinking about the comparison. The state's done a better and better job of it over time. But again, because we're benefit planners, we get the situations where there's an exception. So if somebody is still there, it may well be that they just went to work and they stayed there. Nobody took a fresh look at what other program they might be eligible for. Because when the state really looks is when somebody loses eligibility for Medicaid under one pathway. But we may see, oh my gosh, this person is getting a job. We want to fast track them to HWD because we can see there's going to be an issue. Or somebody got a job and this step of evaluating what's the most beneficial program hasn't happened yet and may not happen for a little while until they get to their 12-month annual review of eligibility. Let's move them towards HWD and start saving them money right away.
Yeah. Does that answer your question?
It does. Thank you.
Okay.
I catch a lot of these, Angela. When I'm out and about, and I present to a lot of parents and individuals in various groups around the state, or I'm starting to move away from that more and trying to get things online. But when I'm presenting, I find somebody in the audience. If there's 40 people in the audience, I'm likely to find at least a couple situations like that.
It's true. All right, Susan, should we move on to the next one?
Yes.
Okay. So now we're going to be leaving the DDA waiver eligibility, financial eligibility groups, and zoom over here. Okay, go ahead, Susan.
So in the interest of making sure that you know there are other ways for people to get Medicaid, even people with developmental disabilities who may not have waiver eligibility, may not need it, or may be waiting for it. There are other ways that people can get Medicaid if they don't qualify in any of those other groups. This modified adjusted gross income group, or MAGI group, is that adult Medicaid group that came about as a part of the Affordable Care Act. This group, can you show the coding, Scott, in the next one? For ACEs, these are codes, I don't think all inclusive, but codes that may be applied to people who are eligible under this, this pathway. So people can get personal care there if they need it. But they can't be eligible for the waiver and be in this group. So it's really a group that works well for people who aren't on the waiver or who aren't interested in being on the waiver. The income standard is based on the modified adjusted gross income level in somebody's tax return. And those numbers change every single year. But it's basically that you're looking at the person's household composition, how many people in the household, determining what countable income is after deductions have been applied. It's available for people between the ages of 19 clear up to the age of 65. It's not available to people who are actively on Medicare. However, it is a good group to look to when you find that somebody is waiting for Medicare to kick in and they need medical coverage. So when I was talking about being in a car accident, I get cash benefits on Title II because I'm not able to return to work. I've lost my employer coverage for health care, and I'm freaking out about what I'm going to do. This could be a group that works really well for me. There is no resource limit. So obviously, if I lose my job because of injury, I don't have the same income that I had previously. This may be a really good group for me to go to in order to get some level of medical coverage while I'm waiting. The amounts that are set, it's actually a total of 138% of that gross modified adjusted gross income. And it amounts to 133% of the federal poverty level that is set at usually in April during the year is when those numbers come out, plus a 5% disregard. I don't know why they don't just roll the whole thing into 138%. Sometimes the logic just defies me, or it defies logic, not sure which direction that goes, but it amounts to 138% total of that federal poverty level based on the household, whether I'm single, there's 2 people in the household, 3 people, whatever the case may be. So you look to the number of members in the household to determine what the number is. You have it. Oh, the other thing is that this is a group that's in yellow because there is no cost of care participation for folks in this group. And there's no resource limit. Yeah, no resource limit. So that's nice.
The only thing I was going to add, Susan, is sometimes I also see people who have applied for Social Security benefits and it's under appeal and they're not getting any cash benefits. and therefore no associated medical benefits. This can be a way for people to qualify for Medicaid.
Yeah, and I've seen it a lot when we're talking about folks that are served maybe through foundational community supports or behavioral health or something.
Yep.
That in order for people to get some level of Medicaid covered services, that this has been a really important advancement in the potential eligibility groups for people.
Yeah, right. Okay, medically needy.
All right. So this group is one that I have to say, if I had to pick one that's my least favorite, this would be my least favorite. And so maybe we should color this one brown or something instead of blue. But the issue with this one is that it is typically very expensive for someone to belong to this program. There is a cost of care participation and spend down that can be applied to folks in this group. And there is the resource limit and no personal care. So it's like, wow, this just sounds like really a losing proposition pretty much all the way around. The ACEs codes you can see there, those are some of the ACEs codes that apply when you see somebody that is in this group. And they're known as MNs, medically needy coverage folks. So that's the coverage group. And when we talk about spend down, you begin to really see that depending on the income somebody has, they may have to spend down a considerable amount in a 3-month or 6-month period before they even get Medicaid paid coverage. And it's all based on the SSI calculations without the benefit of getting no cost of care participation or those other things. They're basically spending everything that they have remaining in order on medical costs before they're even able to get Medicaid covered care. And again, there's a resource limit of $2,000. So it's pretty significant. Mm-hmm. For people that want to be on the waiver, this is definitely not the group to be in. But for most other people, it's almost like you begin to talk to them about how much money they're spending. And if they're not employed, it ends up creating a really great incentive for them to become employed in order to get on Apple Health for workers with disabilities, because it will cost them a lot less in premiums if they're able to do that and get out of this group.
Yeah.
So who might be eligible for this? Remember when we did all of the DAC and pickle stuff and we're trying to figure things out? Well, if somebody doesn't have a DAC exclusion or they don't have a pickle exclusion that is big enough to allow them to remain in that categorically needy program, and maybe they're not on the waiver, so they can't be part of the special income level group, and they don't have a job, so they can't be part of Apple Health for workers with disabilities. Those people, whatever money they have that exceeds that categorically needy income level, which is the SSI federal benefit rate this year of $783, after we've done all of the exclusions, if their countable income is above that level, for people that fit in this medically needy program, they're going to have to spend the rest in order to get Medicaid coverage. So somebody has to still have earnings that are below SGA or be in like that extended period of eligibility where it's an intermittent eligibility for Title II benefits. They have to spend down enough in incurred medical expenses to be able to get the coverage. And the person has to choose how long the spend down period is. They can choose it to be 1 month, or not 1 month, but 3 months or 6 months. So they decide what the period of time is that they would be that would be counted towards the spend down period before they got Medicaid to kick in. So that's something that is individualized based on the person's preference. So let me, in terms of the note, the thing that I want you to know is that the person doesn't have to have actually cut the check and had their medical provider deposit it in order to have met the spend down requirements. It's about incurred expenses. So let's say that somebody had some really expensive thing that happened, and a chunk of that would be counted towards the spend down, and then the rest of it would be eligible for Medicaid coverage. The person won't have had to actually write the check and have it have that amount taken from their bank account in order to be considered to have met it. They've incurred the expense, and Medicaid can kick in after that. But the person is still going to be expected to pay that amount that they incurred. Let's see, what else? The categorically needy income level and the medically needy income level, they are the same. Some states have different amounts, but in Washington state, they are the same, and they're established at the SSI federal benefit rate, 783. This may help to explain it better. Yeah. In order to really take a look at what this program does, so that you can see all of the pieces, including the spend down time frame of 3 or 6 months. So take it away, Scott.
Yeah, sure. So this is looking at, this is similar to the other calculation example. This person has $900 of SSDI and $855 of earned income. So right off the top, we can't exclude DAC with the medically needy income level. And we can't exclude, it says exclude, it's supposed to be exclude PICL or the widower's COLA with this as well. So those are not excludable when we're calculating for the medically needy income level. So let's just go through the standard calculation. You get a $20 general exclusion. That applies to unearned if they have it. So instead of 900 minus 20, it looks like they have $880. Then we look at the earned income of $855. They subtract $65, which brings it down to $790. We'll say this person doesn't have any IRWs. Divide the amount by 2, which equals $395. And that's going to be the amount of the earned income we're going to count. So you add up $880 plus $395, which equals $1,275. Very similar to what we were doing earlier, except without those earlier exclusions. Now, let's subtract the medically needy income level, which is 783, from this 1,275, and that equals $492. So this person gets to choose 2 options. They can spend down for 3 months, which would be 3 months times $492. They would have to spend $1,476 towards their medical costs before the Medicaid would, or before they could qualify for the Medicaid through this medically needy income level. Or they could choose to spend down for 6 months. They would do 6 times 492. They would have to spend $2,952 in costs to qualify under the medically needy income level. So it's a pretty significant amount that they would have to spend. And you know, Susan, in the work that we do when we're working with people with developmental disabilities, I don't see a lot of people that are eligible under the medically needy income level. And then if I did, I would immediately try to find a way that they might qualify for Medicaid through another pathway if that hadn't yet been explored.
It's decreased a lot thanks to Apple Health for Workers with Disabilities. Yes. And I would even say it's decreased across the board between that and the Magi group, that, you know, we're getting to a place where very few people, I would imagine, I don't know what percentage wise it is, but very few people would need to be in this group.
Yeah.
It's really, to me, like when I hear about people being there, I'm just like, ugh, this is probably not really good for you.
Yeah, and like you were saying, Susan, this is something we used to have to calculate much more regularly, but that was quite a while ago. And there are other options that really more advantageous to the individual. Okay, so here we have a section for you to test your knowledge. And we're actually going to set it up so you can, we're going to be using a poll for this. Is that right, Susan? Is Susan there?
Yes. Do you want me to go ahead and pull it up?
Well, let's just, I'll just talk a little bit about this and then we can pull it up. Yeah. So we know we've just given you a ton of information. And in some ways, if you're not using it with an individual, it's still pretty abstract. This is a way to just start to chip away at that and try to apply it. So here are the 5 Medicaid eligibility groups that we talked about today. And they're in the order that we talked about them. There was the eligible for SSI. We say that in quotes because the person doesn't necessarily need to be receiving an SSI check to qualify for Medicaid in that category. There's a special income level of the SIL, HWD, MAGI, and medically needy. And over here on the left are these 7 different situations. And what we want you to do is to look at this and try to identify which Medicaid eligibility group would be the most likely way that the person qualifies for Medicaid, which one applies to their situation. And Susan, I'm thinking we need to give folks just a little bit of time to work on this.
Okay, sure. How much time would you like to give? 5 minutes?
We could do 5 minutes, and then if people need more time, they can ask. Okay. And we can extend it.
So I've pulled up the polling, and you can just respond, and then we'll share. We're not going to call any of you out, so just know that. But we're going to share what the answer is and what your responses were.
I'm wondering how difficult this feels for folks. And this is not to put you on the spot, but on a scale of 1 to 5, 5 being it's pretty challenging. Where do you think you're falling with it? Because we gave you a lot of information.
For me, I think I need more time to go back and look at the previous information.
Yeah.
I wonder if one of the things we could do here, Scott, is to reel back to the first slide where we start to show the various groups and then the ACES codes. Can we do that?
Sure.
So eligible for SSI, we know who the coverage groups are, right? Which is certain DACs and pickles. And 1619B and SSI folks, and the coding is L21, SO1, SO2 are some of the examples. So then the next group, the 300% special income level group is the L22 group, and that's for people that have 3 times the federal benefit rate and are not part of that SSI group. The next one. This is the SO8 group. It's our Medicaid buy-in where people pay a premium. The modified adjusted gross income level group where it's all based on a person's modified adjusted gross income and the limit is 138% of the federal poverty level. You can see the ACES codes for that. The medically needy coverage group, which is the people that have that spend down, and you can see the ACES codes for those folks as well. Now, if we go back to the slide that Scott was sharing with the examples. Here we go. So Shen's ACES code is L22. So in response to that, is he in the eligible for SSI, the special income level group, HWD, MAGI, or medically needy? Remember me talking about the ACES codes and that one of the cheat things that I do is S usually is the Social Security group, and especially if they don't have long-term care. L is the long-term care group, the things that are established around long-term care programs. Do you remember that? So for Chen, what would be your guess? Go ahead and try to click in the poll.
I think the challenge, Susan, is it looks like we have to answer everything and hit submit.
Oh.
Special income.
Okay. So then the next one would be number 2. Ada must pay $1,250 in medical expenses before being eligible for Medicaid. So what group, A, B, C, D, or E, eligible for SSI, SIL, HWD, MAGI, or MN? Okay, I'm going to go to the next one. Yuri is eligible for the waiver. He has saved over $5,000 since working. Which group do you think he is in?
And that's not $5,000 in a sheltered account like an ABLE. That's just $5,000 that's hanging out in his savings and checking.
The next one, Corey lost his SSI due to CDB. He's never worked, and he's on a DDA waiver, the Basic Plus waiver. What group do you think he's in? Eligible for SSI, SIL, HWD, MAGI, or medically needy? Oh, so Scott, you revealed answer number 1.
It was an accident.
The next one is Nikki is eligible for Medicaid. She receives $900 in SSDI. She is not on a waiver. She has no resource limit and pays no monthly premiums. Number 6, is that Asha?
Yes.
Asha is on the waiver. She pays $713 in room and board, plus $385 towards her cost of care participation. And finally, number 7, when Pickle is calculated, Jack keeps his Medicaid. Wow, I've got a whole, for the first one, Scott.
Yes.
I see more are coming in. I'm going to give it a second.
Okay. Everyone should get number 1 right because I answered it.
Okay, so we got 4 of the 5. For number 1, 4 people answered SIL.
That is correct. The answer is the special income level.
So the code that you shared gives you a clue into it being a long-term care kind of a program, right?
Mm-hmm.
So that always kind of helps. With number 2, 4 people answered MN.
That is correct.
I'm only looking at the polling results, Scott, so I can't see the question.
Oh, yeah. So the question is, Ada must pay $1,250 in medical expenses before being eligible for Medicaid.
Very good.
And it sounds like 444 got it right.
Yes.
Okay, the next question.
Ooh, yes. Go ahead, read it.
Okay, Yuri is eligible for the waiver. He has saved over $5,000 since working. What do we got, Susan?
We have 2 answers for him. We have 3 for HWD and 1 for MAGI.
Ah, okay. So let me see what the answer is. It's HWD.
But it could be MAGI.
Well,
you said 5,000. Read the question again to me because I can't see it.
Yes, there's a clue as to why it's not MAGI. Yuri is eligible for the waiver.
Ah, yes. Thank you. I missed that because I can't see it on my screen.
Sure. And he has saved over $5,000 since working. So it's true that MAGI does not have a resource limit, but you cannot be eligible for the waiver through that pathway for Medicaid.
All right, next one.
Corey lost his SSI due to CDB benefits. He's never worked, and he's on the Basic Plus waiver.
This one is very interesting. It's 2 answered eligible for SSI, 1 answered SIL, and 1 answered MAGI.
Okay, let's see what the answer is. It's eligible for SSI. So let me read that again. Corey lost his SSI due to childhood disability benefits. He's never worked. He's on the Basic Plus waiver.
But it could be SIL. Because what if the other income was too high for the eligible for SSI group? You didn't mention income, or did? Oh yeah, you did.
He's never worked.
Never worked.
Yeah.
So it would definitely, depending on making sure that the person lost it when they were an SSI recipient as an adult, would be eligible for SSI.
Right. Okay.
You can see, actually, when we talk about this, because I'm not seeing what Scott's got on his screen, I'm having to try to remember every nuance of what he's saying. And that's one of the really tricky things. Like, people will call me and ask me for information, and I have to write down what they're telling me so that I can keep all of the distinct details, like, you know, when did they lose their SSI? Are they working? Are all of these different, are they on the waiver? All of these different little tiny puzzle pieces have all got to fit into the same pathway in order for it to work.
That's right.
Because it's the minutia that counts here, you know. Okay, next one.
Nikki is eligible for Medicaid. She receives $900 in SSDI. She is not on a waiver. She has no resource limit and pays no monthly premiums.
We have 4 for MAGI.
Let's see if the answer is correct. MAGI. Good job, everyone.
Okay, next one.
Asha is on the waiver. She pays $713 in room and board, plus $385 towards her cost of care participation.
Now, this one is interesting. We have eligible for SSI, 1 person, the SIL, 2 people, and MN, 1 person.
Okay. Answer is, it's the SIL group. So let's see, what are some clues here? First of all, Asha is on the waiver. So that can't be the medically needy group, because you can't qualify for the waiver as if you receive Medicaid through the medically needy income level, that pathway. She pays $713 in room and board, so she's in some sort of alternate living facility, but she's paying for her cost of care participation. Now, if she was eligible for SSI, there wouldn't be any cost of care participation, but she is paying for it. So what that means is that she would be in the special income level. That would be her eligibility group. HWD also doesn't have cost of care participation in regards to, you know, paying money towards, say, your adult family home. And so that's also why it's not an option.
All right.
Last question is, when pickle is calculated, Jack keeps his Medicaid.
So we have 3 for eligible for SSI, 1 for the SIL.
And the answer is eligible for SSI, because that's the only category where they calculate the pickle, and that can lend itself then through that exclusion for the person to maintain their Medicaid eligibility. Was that fun, or was that was that terrifying going through this? I think these are actually like common scenarios that you'll run into, and just like Susan was saying, when you're talking to someone, they're not giving you all this information. We kept it pretty concise because these are like the clues that you needed to zero in on what it is. But as you get comfortable talking to folks and trying to figure out how they're eligible for Medicaid, you'll you'll get quick at being able to just know what questions you need to answer. And as soon as that's answered, you can rule out certain pathways, and it opens up other pathways as possibilities. So it doesn't take long to get comfortable with this, is my point, I think.
If you take that one sheet that has those different groups and print it out for your desktop, and as you're talking with someone or as you're reading through information, start to look at yes, no, for what possible groups fit the scenario so far, and then narrow it down even further. Every time they share more details, you get to where you can look and zero right in on where they are.
Yeah. Yep.
It is terrifying though. And, like I was saying, when Scott was reading the example and I'm looking at your answers, and then I'm trying to remember what the example is, and I'm not seeing it on my screen because I have the poll taking the whole screen. It was hard for me to retain all of the nuances that he gave me without actually seeing them before.
Yeah.
So you're not alone. It's not that it's simple, but it is necessary. It's what we have to do to try to help people figure out where they are and then where they can go.
Yeah. And it just takes practice, don't you think, Susan?
Oh gosh. It does. And you'll find that it takes continual practice. Like if you haven't done it for a while, you're going to have to go back and remind yourself in order to do it well. Yeah.
So this whole chart is just a reference chart, but it does a comparison of some of the features that we've highlighted here, and looked at each one of these financial eligibility pathways and just did a smiley face or a frowny face or something in between in one instance, and also gave some figures. And gosh, I don't know if we need to go entirely through this, but we could look at a few things. So let's look at affected by marriage. Magi, the spend down, this SSI group, and the HWD premium can all be impacted if a person is married. The only group that people are not impacted by marriage would be the people who are eligible under the special income level and they're a client of DDAs. Now the HWD, marriage only affects the premium, correct, Susan?
Oh, sorry, yes, because there is no income or resource limit.
Right. If you looked at the resource limit, Magi doesn't have a resource limit and HWD doesn't have a resource limit, but all the other ones do. That doesn't mean that people can't save money, say with an ABLE account or through a trust fund, but these programs inherently do not have a resource limit. And then participation. If you're on a spend down, you have participation. And if you're in the special income level, you have participation if you're living in an alternate living facility. Now, HWD doesn't have participation towards their cost of care necessarily, but they are participating by paying a premium. And the most it will be is 7.5% of the total income. So that's why we put a sort of a half face there.
All of these things really boil down to, these are means tested programs.
Yep.
It is the headache of trying to make sure that somebody who receives a service absolutely is in need of the service and can't financially pay themselves for the service. That's what causes these headaches and all of these different hoops we have to jump through to figure out how to support somebody in growing their career and their income. And it's really too bad, but it's because, the government wants to prevent those who can pay for their own services from getting the services. So it's really the cause of this headache right here is our need to make sure that we don't have somebody enter through the door and get the services unless they really need them financially and otherwise.
Yeah. And one last thing about this, just at a glance, it's pretty easy to tell which of these is the least, I guess the most disadvantageous, and that would be the spend down. It's nothing but frowns all the way down. And Magi looks pretty good, except that it doesn't pay for the waiver. And in DDA, that's generally where people get their services, is through the waiver.
I could just see people thinking, well, why didn't you give us this table before you ask us to answer those questions, Pat?
I know. I was thinking the same thing. But this is something, you know, some of these slides that we created for this, we were talking about just being standalone documents that could help you or could help people you serve. And so we can take a look at that and pull some pieces out as standalone documents. And then if you have feedback on things that you think would be good, is this like a snapshot of something we've discussed, either for yourself or the people that you serve, we could look at doing that.
I think there was a question. Yeah.
Yeah, this is Susan. I have a quick question about the Magi, the affected by marriage eligibility. I understand, but is the income limit different if they're married?
Yeah, it has to do with household composition. And it's kind of funny in a way because that might not necessarily be super bad. You know, there's typically marriage disincentives, but remember that Magi is geared based on household composition, and you go to the federal poverty limit for that household composition, 1 person, 2 person, 3 person. So that could have impact on that.
And like you said, Susan, it may not be too bad, right?
Yeah.
Compared to maybe some of these others. And Susan, this is the same chart, but for a different group of people.
Yes.
Correct?
Yes. We didn't want to entirely ignore COPES as a potential area for people, even with developmental disabilities, who might be on those programs instead of on the DDA waiver programs. But I think if you take a look at this, it becomes a lot more complex in a variety of ways. And part of the reason for that is that they use spousal impoverishment rules, for instance, which are rules that are set up to assure that a spouse of an individual that is receiving waiver services isn't impoverished in the course of being able to provide those services or obtain those services for the individual with disabilities. And it does make it more complex, and we're not going to spend a lot of time here because you're going to find that the situations where you have to apply these standards are much fewer and far between for people with developmental disabilities.
Yeah.
So we didn't want to dedicate a lot of time to this today, but we did want to provide you with the information. And then absolutely, of course, if you come upon somebody who is actually served through a home and community services waiver, COPES waiver, we will work with you to be able to apply the information that's shown here.
Yeah.
And, you know, more times than not, I end up involving Lori Raleigh in those situations because she knows these rules backwards and forwards. And so she's been really an incredible partner from Home and Community Services that has kind of helped us evaluate things. And I think she enjoys it, being able to look at a married couple, for instance, in COPES and help to figure out what is it we need to do here and what kind of information should this person be provided with or this couple be provided with.
You know, something else, Susan, I've worked in the field of working with people in the DDA community for years. And then I had a little bit of a change and I started providing some benefits planning to people who received COPES. And it was a pretty big learning curve to go from that prior chart that we talked about today to this chart and to try to make sense of it. And I kept confusing it with the other chart. It's almost like trying to learn a new language and the original language it sneaks in there. So some of you may have experience with COPES and some of the details around eligibility are there in your head. They may not apply to DDA. And so having these available is super helpful to be able to look at and just double check your work. They are on the website and available to you, this chart and the one that's for DDA.
And I really think that one of the biggest things is going to be about cost of care participation.
Yeah.
But spousal impoverishment can help somebody be eligible. in copes too, because they might be over resourced as a married couple, for instance, but then when you assign the lion's share of the resources to the spouse of the individual, well, wait a minute, they are eligible. So there are some good things about it. It's just a lot more complex, if you ask me. It's not straightforward.
Yep, totally. Okay, so we're actually coming down to the last few slides. We're just going to go over some additional programs and information with Medicaid. So first of all, we talked about this yesterday a fair amount, so there's not a lot more to go into it, but just as a recap, it's the premium payment program. And if someone is eligible for the premium payment program, they can get possible reimbursement for their private health insurance coverage, whether it's through an employer, private policy, or through COBRA. So if someone has Medicaid, they can apply for this premium payment program, and in return, just depending on sort of the costs of their care and other factors, the state will make a decision if they can reimburse for the cost of the private health insurance. Now, plans purchased through plans purchased through the Washington Health Benefit Exchange, which we showed yesterday, or the Washington Health Plan Finder, but have the premium tax credits. That's where a person pays less than what they normally would for their premium for the insurance. They're not eligible for this reimbursement. But where we do see it, and Susan talked about this yesterday, is sometimes there's people with the developmental disabilities who are covered by their parents' insurance. And so yes, there can be a reimbursement if the parent is paying for that individual's private health insurance coverage. So to apply for this program, they have to submit an application and also a W-9. These are clickable. They go straight to your website where these documents are there. So they should be easy to find. And it can either be mailed to this address or faxed. I don't know what's going on with the fax these days in terms of COVID, if that's a fast method or not. I haven't really heard about that. But these are two mechanisms in which they get that information in. If you want a little bit more information, and there's not a ton of it that's on the website, you can click on this website here and they give you a little bit more details. And estate recovery, and Susan, I was going to have you talk about estate recovery. Are you okay with that?
Yeah.
Okay.
Me too. So one of the things that is going to come up when you're doing benefits planning is people will have heard that they may have dollars recovered from their estate to pay for the cost of care that they received. And it can be a concern to people. I get a lot of these questions for people for whom it's going to be years before it is a concern. So it's just worthwhile to understand some of the basic parameters of the program. Estate recovery applies to the Medicaid services that people receive after a certain age. And for people in long-term care services, the typical age is for those that are over the age of 55. So what does that mean? If I'm on Medicaid and I receive it from the age of 21 through 50, and then I stop receiving it, well then no estate recovery. It's about the services that apply over the age of 55. So when somebody is in their 20s and a parent is concerned about this, I let them know that they're really looking at the milepost being 55 for receipt of Medicaid services and the cost of those long-term care services after that. Some other things that people should keep in mind are that they don't try to recover the cost during the person's lifetime. It's upon the individual's death, and there are some provisions that protect dependents, surviving spouses. If there is a child with a disability that is connected to the individual, they wouldn't allow for estate recovery during that person's lifetime, and the child's lifetime, the adult child with disabilities lifetime, or minor child's lifetime. or the surviving spouse's lifetime. But I can understand why this is a concern. You know, people are worried about what they're able to leave to others. And the thing is that often they wouldn't be able to afford the cost of the Medicaid services themselves. And so there really isn't a lot of option. If they need the services, it's worth it to get them, even if it means that some of the cost of the services might be covered upon the person's death from that individual's estate. But again, they're going to look at the age of the person receiving the services, the dates the services were received, the types of services. In general, though, long-term care services are considered to be something that would be subject to estate recovery. It also is going to look at what part of state government administered the services. But when it comes to Medicaid and long-term care, you're normally going to be looking at that being a provision that applies to individuals when they're over the age of 55. So I think sometimes people have questions about, oh, if I put money in an ABLE, will I have problems then? What do you think the answer is? If you put money, all of your extra money into an ABLE, does estate recovery apply?
Doesn't ABLE have very specific rules about that they passed federally?
And what are they?
Ooh, I know that they got different rules on the trust account.
Uh-huh.
And
yes, and so Alana said, yes, ABLE is still potentially subject to estate recovery. Yes, it is.
Yep.
Now, in the endowment trust fund, Angela, when we're looking at that, there's a difference, right, between whether the trust is a first party special needs trust or a third party. So first party would be the individual themselves puts the money in. Third party would be family and friends put the money in. And so whether estate recovery applies depends on, if it's a first party special needs trust, it applies. If it's third party, it does not apply. Correct?
correct. Yep. And whenever, and I'm not talking directly to families at this time, but whenever they talk to families about that, they try to make that very clear that it's about where the source of the funds come from. So yes, the family money does not have that same recovery provision exactly for that reason.
Mm-hmm. I would imagine that you got a lot of questions from estate planning attorneys and others about this, about, well, then what do we do? What are the potential strategies? Did you?
Yeah. When for a while, I traveled around the state with the trust manager, Tamara Roberts, about that. And she fields the questions at this time about that from attorneys. And that definitely is a question that comes up. And that is a hot topic. But usually when it comes to either families putting money away, or if it has to do with some sort of court settlement, usually it depends on what the source of the funds are, so sometimes it can't be a third party trust, especially in the case of a court settlement. So
Right. Yeah. And we're not attorneys, so it's not our job to act as attorneys. It is our job to give people information about estate recovery when they're asking about it, to kind of let them know where to find more information. And when they're asking highly complicated questions that have some kind of a legal nuance, it's better to provide the rules and let them determine what best to do from a benefit planning standpoint. Right. I do know that there are strategies, though. One such strategy might be that families need to think about what they pass on to their sons and daughters with disabilities or other family members if that person is reliant on Medicaid. Not just because it could impact income or resources, because even with income or resource protections, it does not mean that the services themselves might not be subject to a state recovery if there's an estate to recover them from. So, I think it is something for families to think about when they're thinking about inheritance.
Yeah. Okay, so roads to community living. This is a federal funded demonstration project. And essentially what it does is it helps people who have been in a medical institution, such as nursing homes or state hospitals, or ICFs for individuals with intellectual disabilities, and who have some complex long-term care needs. It helps them to move back into the community. And so there's some special rules around these individuals around their Medicaid. People who participate in Roads to Community Living can remain eligible for Medicaid, regardless of any changes in their financial circumstances, for a 365-day demonstration period. They call that the continuous medical eligibility period. If you see someone with their ACEs that indicate RCL, it would either be L41 or L42. Chances are, though, I'm thinking, Susan, that if any of the planners were going to be working with someone who's part of this project, they would be contacted by someone who was part of a team that was helping them with this process of moving back into the community. Would you agree with that? If someone,
yes,
yeah,
I think that we're going to know very well that
yeah,
they're part of the Roads to Community Living program before we even look at ACES codes. That we would be able to come on board because there's a plan in place for somebody to move back into the community and they want some advice. So yeah.
Exactly. So there's typically a team of people who are helping try to make this transition, successful for the individual. And benefits planning could be part of that, but that information will become really clear if you're contacted. Here's a website for more information if you want to know a little bit more.
That's sort of a get out of the institution free kind of program.
Yes. Yeah, exactly. And I'm having a hard time going back. Hold on a second here. Well, that's okay. But anyways, the rest of the presentation here are just the resources. We listed all the different websites and tools that were listed in this presentation. There's a couple websites here that we didn't mention but are useful. Washington, I might click on this for a second, Susan. So this is Solid Ground Benefits Legal Assistance, questions and answers on the COPES program. This organization puts together some really useful information about programs like COPES. I think they have some things there do they have things there for the DDA waiver? They may. Sometimes when I'm doing research to really get into some of the intricacies around Medicaid or Medicaid programs, and I'm doing a web search, I may find their information. And I found it to be really good and also really easy to read. Because sometimes even though that HCA Apple Health Manual is a great tool, sometimes just having stuff in a little bit plainer language and organized in a way, like the way they do it, can be super helpful. So Washington Law Help. And have you come to these websites, Susan, that they publish these types of information? These Q&As?
Yes. I've had both happen where I provide information to organizations that are trying to create some kind of a handout, as well as receiving information from them.
Yeah.
And, they work closely with the state agencies to make sure that the information is accurate. Mm-hmm. So, like in this case, I would imagine that Home and Community Services was connected with and vetted all of the information. So that layer, it has already been done, where you don't have to worry so much about assuring that everything is accurate. You're going to find sources like this that provide you with really one of the best pieces about this is providing you with something to pass on to people.
Mm-hmm. Exactly. So that's just included in our resources here. And additional tools, all these tools are up on the website for you to poke around and look at. We've looked at most of them already today. And that's it for that presentation.
And look, we are a half hour before the end of our time together. And we could consider that last half hour our final break, although we could also answer questions and provide any clarification, since we do have a little bit of time, and we'll still end up getting out early, I would imagine. So yeah, if you have questions, now would be a great time to ask. Let me ask you this while you're kind of pondering, if you have questions. What did you think about the presentation? Do you feel like you have a better overall understanding of things, even if you don't understand all of the complexities, that they kind of have a better overall understanding, particularly about the way that Medicaid works for people with developmental disabilities and others?
Well, I feel like it's nice to see everything side by side in some of these charts. I don't know that I learned any specific new nuances, but being able to say, oh, easily this is a yes and this is a no, and that's why, is helpful.
Oh, great. Thank you.
Okay.
So it's been a long time that some people have been waiting for these state-specific components, like that you get trained and then you're waiting. And I almost wonder from this group if you're like, oh, be careful what you ask for. I've been waiting for the state-specific stuff, and now I don't know how I feel about having received it.
It's really helpful information, and there's a lot to digest. And I think, as I mentioned earlier in the chat, I think there's some things that I want to print out and have available to me, or offline and download them so I have them, available to, all the clickable options that Scott made available, where you can, go from this slide, to the website. I think will be really helpful resources.
I agree. I thought the training was really great. It was just a ton of information. So obviously I'll just need time to digest, and hoping that there'll be an opportunity to review more examples and look at it and probably ask some more follow-up questions along down the road.
Yeah. One of the things that Scott and I debated about with this is, could we break it into pieces? But it's so for shorter kinds of trainings. The thing that's so hard with Medicaid is there's this transition or movement between programs where if we presented on one group one day and then 2 days later presented on another group, I think that you would lose the continuity in between. But that doesn't mean we couldn't revisit them and focus in on one group, like the DACs and pickles and SSI eligibles, right? We could focus in on that now that you've gotten the bigger picture, to drill down into that and do a training specifically on that, just to shore up your knowledge base. So it's something we could always do. Or the participation rules in those adult living situations. We could get into that and provide more examples and kind of just do a review of what we provided just specific to that group. So that's always something we could take on in the future, just to make sure that you still are keeping that information in mind, that it stays sharp or sharpens in your mind as time goes on. But really, when we were talking about the framework for this training, we just didn't feel like breaking it apart would help you to understand kind of the whole of the work and how Medicaid works and moving between these different options.
Yeah. And I think for those of you that haven't, really dove into stuff around Medicaid or waivers in the work that you've done as a benefits planner, this might still seem kind of, again, like abstract to you, but you have to kind of get into it and do it, be working with an individual, and then it starts to make more sense. It becomes more concrete. And you can look at the charts that Susan created and say, oh, I can see now how this person falls into this category. I think those pieces start to become clear and more intuitive too.
Our expectation isn't that you're experts coming right out of the gate.
Right.
It's that you take a stab at information, that you do research and try to figure things out. But when you get stuck, we're here to figure out a way to help you think about it and apply the information and explain it even. Because I think sometimes, even if you know the information, the first few times that you have to explain it, it's really hard.
Mm-hmm.